All right. I know weather and traffic are holding some people up. I know Elizabeth will be with us in just a few minutes, and so will Richard Pan. But for the sake of trying to stay on time, we're going to get started. So welcome to our first meeting of the year of the our board, Office of Healthcare Affordability. I want to start by calling roll. Who's going to help us do that?
Yes, happy to do that.
Thank you.
Secretary Mark Galley.
Present.
Sandra Hernandez.
Good morning, present.
Richard Kronick.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell.
Present.
David Carlisle. Richard Pan. Don Molds. That completes roll call.
Okay, as I said, we're going to have people sneak in as we sort of advance this morning in the meeting. I think I'm going to turn this over now to Vishal to do what normally Elizabeth Landsberg does, give us some opening updates and HGI updates. So go for it, Vishal. Thank you.
Sure. So I'll be going over the agenda first. It's listed here. We have some executive updates, which I'll present on shortly. Approval of the meeting minutes from the December meeting. And then we have 5 items listed under informational items, the spending target methodology and statewide spending target value. We'll be also sharing feedback from yesterday's advisory committee meeting. We'll have 2 presentations from Anthem and Sharper Steely on cost reducing strategies. And we won't be covering consumer stories on affordability this month. So I meant to say 4 items, but that will be moved to February. And then we'll have an update on the regulations for total healthcare expenditures and the data submission guide. And then our last item will be hospital measurement, and we'll have an introductory discussion on OCA's plan for measuring hospital spending. And then I'll now move into executive updates. So, just as with every meeting, we have some slide formatting. Yellow indicates informational items for the board and decision items for OCA. The green arrow indicates current or future action items for the board. And then moving on to the quarterly work plan. So we're in a new year. This is the first meeting of 2024. We have so far staged out kind of the next 3 months and some topics for future discussion. The items listed here under January are consistent with the agenda. And for the next month, we'll be covering the consumer stories on affordability. And for the month of February, we'll also be covering consumer affordability measures, specifically those that impact, the impact of the OCA program on affordability for consumers and purchasers of healthcare. We'll also follow up on the proposed spending target. In March, we'll discuss board public comments received on the proposed target. And then we'll also share draft APM or alternative payment model definitions, data collection approach, and goals and standards. Next slide. So these are the future topics that we're considering after March. So for the total healthcare expenditure and spending target, I'd like to call out measuring out-of-pocket spending. We heard feedback from many of you on the board, as well as the advisory committee, about the importance of tracking spending by consumers that happen outside of their health coverage. We're looking into medical expenditure panel survey data to see if we can provide some directional estimates on this category of spending. For promoting high value, the board will have several discussions, several decisions to make early this summer about APM standards and the APM adoption goal. The board will also adopt benchmarks for primary care spending. OCA will also review final workforce stability standards early this summer. And then lastly, for market consolidation, OCA's work in this area will provide the board updates on material change notices received, transactions receiving a waiver, or those warranting a cost and market impact review, and the timing of reviews that OCA has taken to review the notice and the time taken to complete a CMIR. And then I'll be moving on to branch updates. So just so that everyone's tracking, OCA is essentially kind of organized into 3 branches. We have the healthcare spending targets branch, we have the health system performance branch, and we have the health system compliance branch, which oversees the cost and market impact review program. So I'll start with health system compliance branch updates. So the first update I want to provide is that we shared this at the last meeting, the regulations became effective in December. We're happy that we have a portal for submitting material change notices live. It's on the HCI homepage. There's also a link on the OCA webpage. It's listed here, and then we also notified those that subscribe to our listserv about the portal coming live. Next slide. Review of material change transactions going forward. These will be reviewed by OCA staff with assistance from economic experts as needed. Notices will be posted on OCA's website. If warranted, transactions will undergo a CMIR or cost and market impact review. Any CMIR will result in a preliminary report, which the parties and the public can review and provide comment on before we issue a final report. And then OCA will regularly report to the board on the numbers of material change notices reviewed, transactions undergoing CMIR, and then the length of time associated with completing those reviews. I'll now move on to updates for the health system performance branch. So these are the 5 areas within health system performance. And it really is to ensure a balanced approach to slowing spending growth. Under the statute, the intent is not simply to have a low-cost system, but to take the best ideas from these areas and reorient the healthcare system towards greater value. Today, I'll be providing updates related to APM adoption, primary care investment, and workforce stability. Next slide. So this slide shows our work group members. Similar to the OCA Advisory Committee that met yesterday, we have a broad cross-section of industry, purchasers, consumer representatives, and advocates, and academic subject matter experts. So this is the investment and payment work group convened by OCA. Next slide. These are the topics that the work group engages on during its monthly meetings. Broadly, the work group helps ensure stakeholder engagement in key OCA program development decisions about definitions and data collection. They provide input and recommendations. They provide input and feedback as OCA develops recommendations for benchmarks. They identify and discuss the relationships and interactions between APMs or value-based payments, primary care, and behavioral health. Next slide. I'll now provide a progress update on this work stream for APMs. OCA has worked with the investment and payment work group from June through November to develop draft standards for APM contracting and draft APM adoption goals. We shared these with the advisory committee in November, and we'll be presenting these to the OCA board in the coming months. We're in the process of revising the draft standards and the adoption goals based on feedback we received from the advisory committee, as well as the work group. Next slide. So this figure summarizes the update I just provided. As you see, we're working towards the June 2024 goal for board adoption. In the March meeting, we hope to share with you the revised draft where we'll get your input and then have a public comment period as well. And I'll now provide an update on primary care investment progress. We started discussions of primary care spend in the investment and payment work group last November. This included a technical subgroup to support the development of the definition of primary care. This including the subgroup met November, December, and January of this year. They considered primary care definitions used in other states. They developed a draft definition of providers, sites of service, and services for claims-based primary care spend. Having attended some of these work group meetings, subgroup meetings, it was a robust discussion. There are differing points of view, especially when it comes to provider types that count as primary care, as well as settings such as retail clinics. And the work group and subgroup are also discussing approaches to measuring non-claims-based primary care spending. OCA will bring proposals from the subgroup to the investment and payment work group for further discussion this winter and spring. And then we'll present primary care investment benchmark recommendations to the board in May of this year for public comment and feedback from you all. And the next slide, similar to the APM adoption timeline, just kind of summarizes what I just said. The end goal here is to have board adoption of the primary care spend benchmark by this July. And I'll now move on to workforce stability standards. So OCA is working with the Institute for Health Policy Studies and the Health Force Center at the University of California, San Francisco, or UCSF, to develop these standards. This slide summarizes our approach. The progress to date is circled in orange here. OCA and UCSF started with a literature review to review current evidence and initiatives on workforce stability. The team also conducted a data set and metric review to review available data sets and identify relevant variables to operationalize workforce stability standards. In late fall, we conducted key informant interviews with state and national workforce experts to discuss how spending targets might affect the healthcare workforce and to solicit insights to inform the standards and metrics. We also conducted stakeholder interviews with healthcare entities, healthcare workers, organized labor, and consumer advocates to get their perspectives. Using what we've learned, we're drafting workforce stability standards, and we'll conduct additional stakeholder interviews to obtain feedback. We'll bring the revised draft standards to the advisory committee, the board, and release them for public comment before finalizing. Next slide. So this again shows our timeline for the work stream. Orange markers indicate where we're currently at, and we'll be drafting standards, getting input in February, March, and then anticipate bringing them to the advisory committee and board in either in March or April. And then by summer, we'll need to finalize these standards in consultation with the board. And then following board consultation, we'll begin to work to implement the standards beginning in fall 2024. And that wraps up my executive update. I could turn it over to Director Landsberg.
Good morning. Thanks very much. I'm gonna skip my updates this morning and can give them at the next meeting, but very happy to be here. And thanks for those updates, Vishal.
Great, thank you. And welcome, Elizabeth. Okay, let's move on to our next agenda item, and that's the approval of, well, before we do that, we're going to have public comment on our updates from Vishal. So let's go ahead and move to that. Thanks.
Thank you. We will now recognize members of the public for comment on the opening agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we'll alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. If you're dialing into this meeting on the conference phone line and you'd like to provide public comment, we ask that you submit your comments in writing via email at oka@hchi.ca.gov, or please join this meeting online if you'd like to provide verbal public comment. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place that matter on a future meeting agenda. All right, we'll start with individuals in the room and turning to the person at the podium.
Beth Capel on behalf of Health Access California. Thank you. The overview, which was also provided to the advisory committee yesterday, really the discussion yesterday in the advisory committee highlighted how all of this works together, how we are in a vicious cycle where lack of consumer affordability means lack of access to care, means that people are not getting timely primary preventive or care or management of their chronic conditions, which is then, we heard from an emergency room physician in an emergency room, showing up in higher acuity patients in the emergency room. And so the premise of OCA is to switch from this vicious cycle to a virtuous circle of better affordability leading to better access, leading to better care and better care management. And it just, these seem like separate silos. They're designed to work together, and if we're successful, that's what will happen. Thank you.
Thank you. Now looking to see if there's any members of the public attending virtually who have raised their hands to speak. We are seeing none. And turning to individuals in this room, we don't see anyone else at the podium, so that concludes public comment. Thank you.
Okay, thank you. All right, now let's move on to the approval of our December meeting minutes. Is there any comments on them from our board members first? No.
I move approval.
Move to approve.
Second.
From Ian. Okay, before we do take a vote, again, open up to public comment.
On this agenda item of approving the minutes, looking to any members in the physical room here who'd like to speak from the public. Seeing none, and looking virtually, no raised hands. So that concludes public comment.
Okay, could we please move to a vote?
Secretary Mark Galley.
Aye.
Sandra Hernandez.
Aye.
Richard Cronick.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
And David Carlisle, not seeing him present yet. Richard Pan is not here yet either. Thank you.
Okay, thank you. All right, so now we move into the meaty informational items as part of this agenda. Let's go ahead. Vishal, I'll turn it to you for our first of these items.
Thank you. Before we dive in, I want to note that we have a number of topics in this category. In the interest of keeping us going and moving forward, I'm going to ask our chair and facilitator to note when we're at time for each of these items, so that we could ensure that we have time for other topics as well. So the first one is board follow-up items from the December meeting. And we have a list of items. So I'll be going over follow-up items to follow up to board requests from last month. I expect many of you have already seen our formal recommendation for the statewide spending target. OCA wants to first wrap up a few of these requests, and I will make clear where input received from the board updated our thinking of the methodology. Until then, I ask that you hold discussions on the spending target recommendation until we get to that portion of the meeting. So I also want to acknowledge one item that's not listed here for today's discussion. During the December board meeting, board member Kronik requested a projection of the impact of a 3% growth rate on the healthcare workforce compared to the status quo. Board member Mitchell also followed up to ask if any analysis is done that we also consider other factors, such as other sectors and administrative, that differentiate between clinical and administrative workforce. Based on our initial review, we did not find any publicly available research on the effects of healthcare spending targets on the healthcare labor force that could inform a projection along the lines requested. In our literature search, we did, however, find several studies that examine the effects of healthcare spending on employment-related outcomes and intend to bring to the board a summary of that literature next month. So I'll first go over the first one listed here, which is a request from board member Kronik for information about healthcare spending as a share of gross state product. So as you see here in the blue line, between 1997 to 2020, personal healthcare spending as a share of GSP grew by 3.8 percentage points from 9.6 to 13.4%. We also include the national data here, shown in the black line. The national data show that personal healthcare spending as a share of GDP at the national level grew by 4.4 percentage points from 11.3 to 15.7%. I want to note that this statistic is different from the typical 17 to 18% share of GDP that you're familiar seeing. This measure for personal healthcare spending does not include public health activities, health insurer admin costs and profits, government administration, and investment.
Make a very quick comment on this. Thank you for this. The blip up in 2020 was almost entirely from federal funds going to hospitals and other healthcare providers for COVID. And at least the national data for 2021 is back to the 2019 level. And so the basic story is remarkably flat spending, as remarkable for the US, flat spending as a share of GDP for a decade, with the, this 2020 blip up, but then 2021 back down.
And then continuing on to the next slide, we were also asked by board member Kronik about the extent to which a 3% spending target would affect healthcare spending as a share of GSP. If personal healthcare spending grew at 3% from 2025 to 2029, it would amount to 13.7% of GSP in 2029. This effectively returns to 2021 levels. By contrast, if personal healthcare spending grew in accordance with CMS national projections from 2025 to 2029, it would amount to 15.2% of gross state product in 2029. And I'll move on to the next board follow-up item. Several of you have asked OCA about alternative approaches to analyzing median household income data. Specifically, we were asked to update the 20-year time series of median household income data to include 2022 and examine weighted averages that assign 100% weight to the most recent decade, which would be 2013 to 2022. When we did this, we found that from 2002 to 2022, the unweighted average change in median household income growth is 3%, as shown in the first bar. If we assign 100% weight to the 10-year period from 2013 through to 2020 or 2022, and 0% to the 10-year period from 2013 to 2012, it yields 4.2%, which is the last bar shown on the graph. And then OCA, notes that a 20-year period here is used to calculate the average because there's too much fluctuation in a potential target value when looking at 3-year, 5-year, or even a 10-year period. Next slide. We were also asked by board member Pan to examine 5-year running averages. This mean takes 5-year averages starting from the period 2018 to 2022, then 2017 to 2021, 2016 to 2020, and so on. The left graph shows these 5-year rolling averages from 2002 to 2022. The average of the 5-year rolling averages is 2.9% and yields a minimum of negative 0.7% and a maximum of 5.3%. And then on the right, if we were not to do a 5-year rolling averages, the minimum and maximum is negative 3.3% to 10.8% respectively. And going on to the next slide. So during last month's meeting, we're also asked to provide some background on median household income growth from 2018 to 2019. OCA staff flagged 2019 as a year with high median household income growth, and several of you asked for more context on this. We looked at a working paper by 2 Census Bureau economists that examined survey response rates. Interviews for the current population survey for 2020, which captures information for 2019, began in March 2020 amid the onset of the COVID-19 pandemic, which presented considerable data collection challenges. The authors find evidence of differential non-response, where higher income households were more likely to respond, and estimate that it upwardly biased income statistics by 2.8%. Next slide. So if we were to apply the differential non-response adjustment for 2019 to the California time series, the changes would be minimal. The unweighted average remains unchanged. The 5-year rolling average now yields a minimum of negative 0.7% and a maximum of 4.7%, which is down from 5.3%. Assigning 100% weight to the 10-year period from 2013 to 2022 and 0% to the 10-year period from 2003 to 2012 now yields 4.1%, which is down from 4.2%. I'll go on to the next topic, and I'll turn it over to CJ Howard.
Good morning. My name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets branch. So there was a request for us to investigate the potential for technology and artificial intelligence to potentially adjust the target downward. During the December board meeting, we did uncover a 2023 study that estimated that widespread adoption of AI nationally could yield annual savings between 200 and 360 billion. I'm putting that into the California context. That's somewhere on the order of 20 to 41 billion, or an annual change or decrease of 5 to 10% in spending compared with the status quo. We do note that this was one study. I think that we would certainly encourage more investigation on this, and it also assumes uniform adoption of AI across the industry. And I think, as we discussed in the December meeting, that adoption of technology is not necessarily uniform across industry. And so I think, to this extent, we would still we would caution against using these numbers too quickly, or caution against using an adjustment for technology at this time, but that we would want to continue to research and investigate this. This topic also came up at the advisory committee, just the notion of technology and how to potentially adjust the targets for technology. There certainly were voices in favor of future downward adjustments as technology is phased in and used in the healthcare setting. And on a related note, one individual on the advisory committee suggested that we OCA investigate the trend in specialty drugs, kind of as not necessarily AI, obviously, but as a form of medical technology, and specialty prescription drugs, and assess the potential impact of those cost trends for an adjustment to the target, potentially upward. I'll hand it back to Michelle.
We were also asked about the performance of other states that have spending target programs. So we have some materials for you, and I'll turn it over to Michael Bailett to walk through those.
Good morning, everyone. So as you may or may not recall, Massachusetts passed a statute in 2012 establishing its spending target program. The flurry of states that replicated the approach didn't begin for several years. And so the next states to have spending target data published against their spending target was in 2019 in Delaware and Rhode Island. And then, of course, we know what happened in 2020 and 2021. So unfortunately, Massachusetts is the only state where we have a track record of being able to assess performance. So I want to summarize first, what do we know about Massachusetts' performance against their spending target? And then what do we know about performance in the 2019 to 2021 period for a broad array of states? And then I'll share with you some early read on what state data look like for 2022, not yet published. So for Massachusetts, between 2012 and 2021, their spending growth was about at the rate that their average target was, so 3.5%. As I've shared with you before, what's especially notable about Massachusetts is what happened in its commercial market. In its commercial market, prior to 2013, they exceeded the national average annual rate of growth in 6 out of 7 years. Starting in 2013, they were below the national average in terms of rate of growth for 7 consecutive years. So that appears to indicate some impact from their spending target initially. I will note, though, that in the most recently reported year, 2021, they grew faster than the national target, which has caused some concern in that state. If we look at 2019 to 2021, as I've described before, in 2020, per capita spending growth as measured by the states was negative, and that's because the influx of federal relief payments were not captured by the states. They didn't have any way of capturing that spending. So absent that, it looked as if spending declined, and that's across the board in all the spending target states, and that's what happened in Massachusetts. And that was followed by a big jump up in 2021, both because 2020 was depressed and also because there was a big increase in utilization because of deferred care during 2020. Okay, so this is what we saw in Massachusetts. Their annualized rate, 2019 to 2021, was 3.2%, but that includes a decline and then a big increase. Okay, the next slide summarizes information from the other states. Next slide, please. Oh, I'm sorry, Massachusetts first. So this is the distribution of performance against their spending target. You can see in some years they were above, in some years they were below. Their highest year was the year that Sovaldi was introduced into the market and the year in which they had a gigantic snafu in their Medicaid enrollment system. But overall, they averaged about what their target was. And their target did change over time. It started at 3.6%, which was in statute. And then at the discretion of their Health Policy Commission, they moved it down to 3.1%. Okay, and then the next slide is the one that covers the other states. So there were 5 states that publicly reported performance for 2020 and 2021. Only Rhode Island met its target for this time period. Oregon was off by 0.1 percentage points, so approximately at their target. The other 3 states were quite a bit above 3 to 8 percentage points. As I may or may not have noted in the past, there was huge variation, actually 100% variation in growth in commercial market spending across all the cost growth target states in 2021. Rhode Island being the lowest, Connecticut being the highest, 2 little states right next to each other. I want to note that the increases in 2021 were driven by both increases in payment per service unit and payment and growth in utilization, although primarily utilization, and heavily in hospital outpatient utilization. And how do we know this? Not from their spending target data submissions, but from their cost driver analyses using their all payer claims database. That's where they gained that insight. Finally, I'll give you a little informal preview on 2022. It looks like spending growth in at least 3 states for which I've seen 2022 preliminary data is close to their spending target in all 3 states. I do not know that that's going to continue for the next 2 years, but for 2022, performance in the 3 states that I've seen so far looks pretty good relative to their targets.
Michael, thank you so much. One question that I think I've always been confused about. In Massachusetts, I know that, or I think that for the assessment for individual medical groups of whether they have met target or not, that they do clinical risk adjustment, and that there's been about a 1.5% to 2% a year measured increase in risk. And so that these groups are getting kind of unless you think there really is an increase in risk, which I think most people in Massachusetts think is not the case, that the medical groups are getting a 1.5% to 2% kind of free pass. But the statewide target information that you showed us, I think, is not adjusted for clinical risk. Is that
yes,
correct?
Your understanding is correct.
Thank you.
Secretary Galley, could you use your mic?
Oh, apologize. I will repeat it. Thank you for the presentations. Before we keep moving forward, I want to make sure board members can ask additional questions to any of the items, including back to Michael, if that makes sense, about what was presented, especially those who asked for the additional information to make sure that there isn't follow-up after seeing what the team has brought back. So just create that space for board members. Start with you, Elizabeth, and then Richard, and keep going. Yeah.
Thank you, and thank you. I'm just confirming that the question about wage impact across sectors, that's going to come back at a future meeting. Is that right?
So we did a search of the literature, and there's not any research studies on the impact of a spending target on labor workforce. but we did find additional articles about the impact of spending growth on employment-related outcomes. So we intend to bring that back.
And looking at the impact of healthcare costs on wage growth generally.
I'll have to take that back. I think the studies we did come across, it was more about the high cost of care and then that leading to people not being able to afford their insurance and some negative employment and health outcomes associated with that.
There are some studies that show the impact on wage growth, which I think.
Oh, yeah. I think there's one that came out recently that we're aware of as well. So we'll bring that back in next month.
Thank you.
And as a board member, feel free to share some of the things you have at your disposal to enrich the conversation as much as possible. All right, Richard Payne.
Thank you. I appreciate the conversations. So just looking at the 5-year rolling averages, it would be nice to actually have the numbers for each of the 5 years because I note in the graph it's lower at one end and higher at the other, and 20 years is an arbitrary number. So it looks like the more recent, actually 8-10 years seem to be, so you have the next one. Yeah, so you see the graph, right? The other interesting thing to note is that certainly with the Great Recession, that's probably the negative 0.7%. Did we really think healthcare demand went down and people's needs went down by 0.7% that year just because of an economic recession? So I think we got to take account of counter-cyclical issues. I mean, this is something we deal in the state budget, right? Even as our revenue or tax revenue is going down, we are highly dependent on high income earners. Doesn't mean that Medi-Cal demand has gone down, right? And so we need to, as we pick a measure, we got to think about these things because otherwise, I mean, and if someone's had to, who started off in the legislature with $28 billion deficit, we're asked to make cuts to the very programs, and that's why I worked to get a $30 billion reserve. Because what happens is that, yes, the economy and the need for services, particularly including healthcare, they do not correlate so directly. And in fact, I think that, so I just want to point that out, but I also want to point out the 5-year rolling average shows that actually for not just 1 or 2 years, for many years, it was lower at the first half of the 20, but it's actually, you want to take account more recent. I mean, we did the whole other exercise with, if how do you weight the two sides? But again, I think this demonstrates that there's higher. The other thing I also want to bring up is, I appreciate that we looked at AI in one study, but AI certainly has not been proven technology yet in the application to healthcare. So, for example, with great, IBM went through and said, hey, Watson, the thing that I think beat everybody at chess and Go and everything, they tried to apply it to oncology. You don't hear about it much because it didn't work, right? There's a paper in JAMA that came out recently, showed that diagnostic accuracy of AI, and they actually said it was better than a lot of other ones, was basically around, 30-some% or something. So, the results aren't good. So, I mean, I appreciate people saying, oh, look, if we can have AI, we're going to lower healthcare costs. That's all speculation at this point. I mean, do we have how many proven AI things do we have that are of what hopefully that we would accept as acceptable quality that has demonstrated lower healthcare costs yet at any significant scale, right? Now, the reason I brought up last time about genetic therapy is that that's a little different. We have an FDA-approved treatment for sickle cell. So in other words, I'm not trying to speculate. I'm saying that when we talk about technology, we're talking about technologies that have proven enough that they've even gotten, it's not experimental anymore. It's now gotten, universal approval by the FDA. So, so when we think about where we want to go on technology, let's, we even talked about last time, let's stick to the stuff that at least is, gotten past the experimental stage and speculation stage. And we actually probably are going to start having some data on that. So, so I appreciate the talk about AI, but I haven't seen anything that, and I'm in the healthcare field, that says that, it's speculation what AI can do. There's a lot of hype about AI right now, but I'm waiting for something that actually works well enough. And most of the stuff that's come back so far, I'm not saying it won't ever, but isn't particularly impressive at the moment. And certainly I would like, not to have an application that's wrong more times than it's right, and saying that that's going to, quote, increase efficiency now. So, but I would make note that, the 5-year rolling average, if we're talking about 5 years in, actually in the second half, and if you don't like 20 years, why not 30 years, 40 years? We can go backwards, forwards. But I think what we did talk about weighting things more recently, and so I'm not just trying to cherry pick 1 year. You look at that, right? And even if you do the adjustment for 2019, right, that's right, as you pointed out, it'll lower a little bit, but essentially we're probably more, that line looks like, if we had the actual numbers, it'd be easier, but looks more like it's hovering between 4 or 5% now for many years. Okay, thank you.
Thanks. Ian?
Yeah, I two items. I did want to address the last two comments on impacts on wages. I mean, that period, the 2007 period where incomes were going down, I mean, I remember that distinctly. It was also the period that premium rates were going up at the fastest I have ever personally witnessed. And it was a point in time where, I witnessed many conversations among groups of organized workers who had to make the decision, even in an environment where their working hours were going down because of the recession. They were voluntarily taking wage freezes in order to continue funding the healthcare and supporting the premium increases. So that was a counter-cyclical moment and a very painful one. I did want to ask Mr. Baylett, I'm quite intrigued by the 100% variation on commercial rates, and not asking you to go do a bunch of extra work, but to the extent that you have statistics on kind of the history of specifically commercial side premium rate increases, pricing increases in the states that have spending targets, and California also, that you share that with us, if that data is available.
Okay.
Great.
Sorry.
Okay, go ahead. Sandra, we'll come back, Elizabeth.
Yeah, I wanted to follow up on the Massachusetts data that you presented, Michael. And you were talking about the period of time where they went substantially above their target. That was Sovaldi and Medicaid.
Mm-hmm.
Can you elaborate on the Medicaid piece of that, please?
So they had an eligibility enrollment system snafu that resulted in a lot more people being covered and spending being included. And I think during this time period, that they captured the spending, but they didn't capture all of the lives because of the enrollment snafu. So it inflated what their per capita spending growth looked like for that year.
Thanks, Sandra. Rick?
Thank you. Could we go back to the slide that Richard asked us to look at, the 5-year rolling average slide? Yeah, thank you. This is, I think, a kind of tough one. And, I understand the arguments, and we discussed this last month, so I won't belabor it or overly belabor it. I guess I'll belabor it a little bit. 20-year average is going to give more stability than a shorter period of time, less stability than a longer period of time. As Richard said, you could have a 30-year average or a 40-year average. You'd have even more stability. Looking at this, it does seem to me that a better prediction for the next 5 years would be to put more weight, I would say 100% weight, on the last 10 years than on what was the worst recession that we've had since 1933. Obviously I do not know what median household income growth is going to be for the next 5 years. But in looking either at the left-hand side of this or the right-hand side of it, I would think a better prediction for the next 5 years would be something that took the end of this period. You have on the left-hand part of the graph, the 5-year rolling average is pretty flat. starting in 2012, I think that is, or 2011, 2012. And, you know, the individual years on the right-hand side obviously have much more fluctuation in them, but if you sort of draw a line, you know, through the 4.1 or 4.2% that those things average, it looks pretty different than what came before in the Great Recession. And I don't know, I mean, it just seems odd to, I understand the rationale that, you know, greater stability is good, and a methodology that only use 10 years is going to have a little bit more fluctuation than a methodology that uses 20 years. But especially given that, you know, the 20-year period includes the worst recession since 1933, I do think a better prediction of the next 5 years would be using, you know, the last 10 rather than the last 20.
I think helpful perspective. I think, you know, one of the reasons we did this was to try to sort of accommodate a lot of different approaches. And as I said at the end of the last meeting, one of the things I have been consistent with the team around is that we need to have a thoughtful methodology. There's a lot of different ways to do this. I think you could pick different time periods. You could do rolling averages. You can present them as individual data points every single year. And I think part of the purpose of presenting this is how, don't want to dispute your experience and certainly your perspective on it, but how do we come up with something that allows us to do what this body was put forward to do in an effective way? And that's, I think, the struggle of how to take each perspective and build it into a final outcome here. And I think look forward, again, remind people we're here today. We were doing this last month. We're going to do it again. We're going to have chances to bring back some information. So I just suggest we continue to struggle with this a little bit. I don't know that we're going to land something immediately, but hopefully we get the richer perspective from those here and the work that we'll continue to do. So I just want to acknowledge that. Sometimes it's hard. You hear a good, thoughtful comment, and then you move on to the next one, and it shouldn't always be that way. But Rick, I think it's a really important perspective to have. Richard, I'll come back to you in a second. I want Elizabeth, you had your hand up for something more.
It wasn't this, but I appreciate the confidence that there won't be another recession. So I think that this should probably be part of the reality. But my request was actually quite simple. If you do pursue sort of Ian's question, I think recency there is very important because we did have sort of 10 years of relatively flat trends, but that is spiking now over the last couple of years. So just think that needs to be factored in. The commercial rates are going up much more dramatically than they were.
Thanks. For board members, mic on, speak up and close to it if possible. I know it's not always easy to remember. Richard.
Well, appreciate discussion, obviously, and so forth. And again, I hope that we will look at. I mean, we're going to do AI. We should be looking at other forms of technology as well. The other thing I guess I would say is that even as we're trying to figure out methodology, come up with quote the number, which we have to by June 1st, is that we also have a discussion about how that number is going to be applied. Okay, because that just becomes that's a number, right? And then so what does that mean when someone's quote above, well, below probably not an issue when they're above, right? And how do we factor that, right? And that that there's consistent standards. People have expectations about okay, what do we flex on, right? So it's not an arbitrary thing. Oh, I like you, I flex for you. I don't like you, I don't flex for you, right? So what kind of things, what standards are we going to apply? Because we're supposed to do, well, first of all, the first target isn't enforceable, but we're doing X number of years beyond the first year. Those subsequent ones are. So ultimately, if we come up with a multi-year, we agree on a multi-year, we are doing enforceable numbers then. So, right? So, I mean, only the first year is not enforceable. So I just want to be careful about that, right? And if we end up doing 5 years, that's 4 years of 3 years, whatever else. So, and then the other part though is that having because we're a big diverse state. So Massachusetts, you got Boston. I used to live in Massachusetts. You got Boston, you got rest. All due respect to Worcester and some other places, right? But California, I mean, compared to a lot of the other states that are doing this, Oregon or something else, is that we have a lot more diversity, not just in terms of geography, economics, et cetera, in different parts of our state, right? And that's going to have an impact on what happens locally. That's why eventually we are supposed to look at geography and sectors and so forth. But I think I would like to hear a little more about, so that we are setting some clear expectations about what kind of things are we going to take and adjust for, not only just globally, and there's things in the statute about how we should be adjusting our numbers depending on things coming up, but also at least somewhat broadly, not institution by institution, but what are kind of things that we're going to factor in, especially in line with the statute, but also how we're going to operationalize that.
Yeah, I'll just comment. I think it's a very valuable point, and I'll remind folks we have an objective by June for sure, but we don't go away after that. We're here watching it. We're setting a multi-year target, but we're meeting every month in between or at some cadence talking about how it's going. And I'm sure we're going to have a lot of interest in sort of looking at how things are. And I know some people think, well, you're never going to set it here because you're never going to go down, or you're only going to be pushed up, or vice versa. I mean, Massachusetts chose to go down. I mean, there's all of these different traditions. So we should, the independence of this body was set for a specific reason, to be able to continue to struggle through, hey, are there better ways that emerge? I appreciated at one point when we had Massachusetts come to our early meetings, Michael, you facilitated the whole notion of shame and transparency, I heard starts to extinguish after a number of years, and then the hunger for different kinds of tools and different levers are there. So we're going to have that same journey on our own. So I appreciate, even if we don't to an endpoint today, deliver on some of these follow-up items. I think it's just enriches our ongoing conversation. Excuse me. Don, go ahead.
Thanks, Michael. One other question. So, one of the issues we spent a chunk of time on the last meeting was this question of whether or not a given spending target was going to have a detrimental effect on access, et cetera. Most of the other states are sort of in the 3% range. Where are they? Where did they start is the question. So we've been looking at, the data that you were just sharing sort of looks at the experience after the spending targets were established. The question is, what did it look like before the spending targets were established? Is the gulf between where they started and where the spending targets were established significantly lower or higher than what we're talking about, or is it similar? Because if it's similar, we may be able to look to them and see our future a little bit and start to answer the question about the effects that it has.
Yeah, I don't have the information in front of me, Don. Thanks for the question. I think I might have shared some of this at a prior meeting, but in some of the states, they started at a higher point and they ramped down. Rhode Island did not. They just picked a flat point and went with it. So they all started at what I'll call a discount off of historical spending growth. The end point of the discount, or where they got to their steady state value, was, if I can recall, somewhere around 60% of historical spend. So that was the discount in terms of the percentage of historical spend. There was a range, obviously, and I can dig out that information and share it with all of you.
Can I add to, I really appreciate the comparisons from other states, especially those who have a little bit more experience than we do in doing this. Two things that I don't need to answer now, but add to the list of follow-ups for you, Michael. One is just Rhode Island, Connecticut, small states, neighbors, radically different outcomes. Like what is behind that a bit would be really helpful to understand.
I can answer that for you right now.
Beautiful. Go for it.
Very different market structures and overall environments. Rhode Island has a commercial hospital price growth cap. So that's a regulatory limit on how much commercial insurers can increase their hospital prices. That's had a tremendous impact on their spending growth. Connecticut does not have that, and they have a highly consolidated hospital market in which the major systems, of which there are two dominant systems, have a lot of influence over commercial contract prices.
Okay. I mean, again, that sort of information is super helpful to thinking about how California's markets are structured, because I appreciate your point, Richard, about how big and diverse we are, but within the same geography, you can have very different markets. We've heard very in compelling ways about some county related markets through public testimony here, and I know we're going to hear a little bit more about that, but I'm certainly interested in us taking into account more of that. And then as it relates to Massachusetts with the longest history here, what are the characteristics of those systems, getting down to the system level, that hit the target regularly or don't? I mean, is there a level of integration? Is there the same consolidation? Like an integrated health system, does it, have they traditionally done sort of better or the same against that cost growth target? It'd be good to dig into that next level of detail the next time we get together, because I think it would inform all of us a bit on how do we think about this target and how it drives those market characteristics a bit in California, which I think we're all interested to understand that a bit more.
I think it's reasonable to anticipate, just based on public literature, that markets within the state that are highly competitive probably have slower price growth than those that are not.
Mark, could I just?
Sandra, please, yeah.
So, Michael, now you got me curious about Rhode Island. So the hospital regulatory environment with regard to their rate of rise of costs, was that coincident with them sending the spending target, or did that pre-exist the spending?
It pre-existed.
Their regulatory structure is set up somewhat differently than ours too, like how they, yeah. Okay, other questions, comments, and staff will kill me for saying this, or maybe not, but I'll say it anyhow. Any other follow-ups, people? We've given it all to Michael. Other people want homework assignments tossed to our team. Elizabeth, you raised one additional, but others? Go ahead, yeah.
I said we only heard about AI.
Yeah.
There are actually more technology that's actually further along than AI that we should be talking about, and perhaps most notably biotech genetic therapies, right? Which actually, I said, the Me Too drugs are one thing, but the ones that actually lead to cures, but so that's what happened with sickle cell. Sovaldi, in some senses, was kind of quasi the first one, because again, there was a comparison between actually curing Hep C versus treating them as a chronic disease.
And I'll just pile on the AI issue. I think you're speaking, Richard, primarily about its application in clinical delivery systems, and does it help disrupt it, make it easier, better, whatever you want to look at. On sort of the administrative side, it feels like there's probably even more evidence that some AI tools could change that entire way that it's delivered, and does that have some impact that's worth looking at? So in our look at AI as a specific piece, do we have any sense of how that might nuance out a bit? Okay, Rick.
Sort of adding on to Don's request about information about premium increases, I think Don was asking about 2022. It's my memory, but maybe I got that wrong. We all, folks who have been involved on the purchasing side, have been, as well as consumers, hit by the premium increases in 2024 in California with, I think, general expectations for, still too early to know, but, relatively perhaps a bad year in 2025. And the sense that I have in 2024, not good data, but, that this was largely utilization driven and not price driven. Don, you may have better information on that. Both, yeah.
It was both.
Yeah.
But it was, it was, there was more of a utilization trend than we've seen typically over the last several years, but it was definitely both.
I think it'd just be useful to, it feels to me a little like we're swimming upstream, and that as we think about the experience of other states that have set cost targets, primarily did it in kind of the 2019 timeframe, or in Massachusetts 2012, we had this decade that we saw of spending that was flat as a share of GDP. We don't know what it's going to do nationwide in the next 5 years, but the Office of the Actuary projections at CMS will go back to some level of increase. And certainly our experience in California in 2024, at least at CalPERS and the University of California, and I think other large employers, was pretty bad. And so getting a little bit of that information in front of us somehow, and the Kaiser Family Foundation employer survey won't be available, and the MEP survey data won't be available. Maybe kind of Watson Wyatt, or I'm not sure exactly who has real data, but as we're getting to June, having some information about more recent spending trends would, I think, be helpful.
Okay, thank you. One last one, and then we're going to move on to the next part of our presentation.
The other thing is, I know we're going to talk about workforce stability, I think, later in the agenda, but a couple of also thoughts is, looking at, so far I haven't heard anyone said we have too many healthcare providers. Everyone keeps saying we have a shortage of mental health, we have a shortage of this, we have a shortage of that. So getting, and it sort of ties into our workforce stability, but basically healthcare workforce plus, of course, on the financial side, sort of average or what the labor costs are, and to meet the need, right? So right now we're hearing a lot of shortages and nurses leaving and so forth, and other healthcare workers, and of course, we even took policy steps to try to address some of that, which are, I think, important, and so, but that needs, and we, so I think we need to factor that in. The other thing is, I would also make note is we quote look at 20 years and so forth. Within that 20 years, not only did we have the Great Recession and so forth, well, we did the ACA. Right, we're expanding healthcare coverage starting this year to undocumented. Now that's sort of, so we think about spend per capita. So again, that depends on what the numerator, the denominator is, and we know there's some, not that people who didn't have insurance, they still got care, or perhaps, but someone got. But I think just sort of thinking about secular trends, another thing to think about, thankfully, our efforts at trying to get closer to universal coverage, right, and how that might impact, quote, total spend, right, because there's a lot of deferred needs that happen. We saw that with the ACA, that there were suddenly all these folks who, and by the way, it didn't just happen the first day because we had to educate people to et cetera. But it basically, you had, people who finally got healthcare coverage, you had a bit of a bump because you had deferred needs that need to be met that they put off because they didn't have healthcare coverage and so forth. So this all happened in the, frankly, in the last 12 or 13 years, right? So with the ACA rollout, and then of course further steps that we took here in California, which are good ones, in my opinion, but I think, again, our factors, and we just heard Massachusetts had a thing where, well, the enrollment, et cetera. Well, that tells you how powerful that can get, if depending on how you count the numbers.
Okay. Ongoing conversation, of course. Let's go back, Vishal, to you. Talk about where we are, timeline on the proposal for the spending target.
Great. So CJ will start off, and I'll take over after him.
All right. So this is just a brief overview of the timeline and process for adopting the spending target or the initial set of spending targets. So a brief overview of the statute, and then I'll show this in a timeline and then revisit it in kind of a stepwise progression with a little more context. So the first provision in statute essentially is that the board will hold a meeting to discuss the office's recommendations. The board shall consider input from the office, the advisory committee, and the public, and then must discuss again at a subsequent meeting. So that first meeting is the meeting that we're having here today, because as the second provision in statute that's pertinent here is that the office needs to publish on its website its recommendation for a proposed cost target. We did that last week ahead of our March 1 deadline that's established in statute. So today we're discussing the office's recommendations, and triggers today a 45-day public comment period, which I believe closes on March 11. And then the earliest that the board would adopt the initial statewide spending targets would be at the March meeting, though per statute it must do so by June 1. So again, just kind of putting this into a visual timeline, on January 17th, we recommended a proposed target. We discussed this with the advisory committee yesterday. The board then discusses the proposed target, that's today. There will be another board meeting in February. March 11 ends our 45-day public comment period. And then we have our board meeting, we have a board meeting in late March, and then subsequent to that, at that meeting or a subsequent meeting before June 1, the board shall adopt the final target. The board, so I think the most pertinent bullet point here is the last one. So the board is required to adopt the final target by June 1, but this target can align with the office's recommendation or be another value that is discussed and agreed upon by the board. There are questions about the sort of general timing and process.
I just want to, for the sake of clarity, the 45-day period would end before the March meeting happens. So we could, just so I'm not suggesting we do, but you could move to adopt it in March, April. Is the June meeting too late? Oh, sorry, I skipped over an entire month. Which will, May
Would be the last meeting.
Okay, is the last meeting. So at a minimum, we will have a couple of months to digest all the public comments, keep going through, but we don't have to use all of that time. We could adopt it earlier if we hit that sort of agreement to take up a vote. I just wanted to make sure that's clear to board members and for the public record. Yes.
When is the advisory committee meeting? Are they going to have a meeting post public comment as well, so they can digest that and then give us their input? So when's their meeting?
We received their input yesterday, and their comments would be part of the 45-day comment period.
So they won't have an opportunity to review the comments and then digest them and then give us some recommendations or comments or thoughts. I would think that would be really helpful for also the advisory committee. And I think when we envisioned the advisory committee, it wasn't just like they were floating out there. They should also have the opportunity to review the comments after 45 days. They give their thoughts. I mean, after all, they don't even give an overall recommendation. I think, and then that would help inform, I think, our deliberations as well.
So CJ,
there is an advisory committee meeting in April.
But the statute doesn't require that we get the advisory committee's reaction to the 45-day comment period. They're part of the 45-day.
Okay, all right, but let's put it this way. I think, right, we can argue about what the statute says, but part of the reason for the advisory committee is not just to have them sort of out there and they're just another commenter, right?
Yeah, I think part of my question was to sort of lay the earliest we could do this is the March meeting. The latest we could do it is the May meeting. I think your important point is that if we so wanted to have the advisory committee release their reaction as a valuable piece of our own deliberations on setting it, we could get that in April, which would de facto put us, I don't know if it is, but my guess is it puts us into the May meeting as the likely time we move to adopt it. So I'm not suggesting that's what we do. I just wanted everyone on this group, on this committee to understand what our options are.
And
Yes.
I mean, I assume the advisory committee date isn't necessarily set absolutely in stone. So if we decide that's a sequence and we think that April's too late, we could ask them. I mean, it's January. We can ask them to
have
convene
some
earlier, right?
leeway.
Yes.
So good to have all of these options in front of a group that's going to make decisive decisions. Okay, go ahead, Elizabeth.
Just confirming though, the deadlines here are in statute.
Yeah, this June 1
Yes.
is in statute,
that's
so
not up to the
we have to commit, if we haven't done it by 5 p.m. on May, whatever day, 31st, we're in trouble. Maybe midnight, 11:59. But yes, we'll get there. We'll get there, hopefully sooner. Yes, go ahead, Rick.
Just a question of clarification. So this is all around adopting a target. I know we've also talked about adopting a methodology, but I don't see that here. Is that not something that we are required to do, or?
Yeah, that would all be part of that spending target, including the methodology. Yes.
It's a good question, though. Do we have to, I mean, are they two separate actions? This is the methodology and this is the target?
It could be one item.
It could be one item.
Yeah.
Okay, thanks. All right, look, see, we're all spinning.
Actually, remembering the statute, I will point out, and certainly anyone can correct me if I'm wrong, but I remember negotiating when we were talking about this, is that if we don't come to an agreement in May, we will convene on, I think, June 1st, and we cannot leave the room until we actually vote about one. I don't think that's going to happen, but that is a requirement.
That's a motivator to all of us to figure it out way ahead of time. Okay. Any other, okay. Please share that as our wise
legislation which lays out the 45-day period says the board shall receive and consider public comment, but Bagley-Keene still applies when you receive a comment. If you're meeting with people, that you have to be aware that serial meeting prohibitions still apply, and that all consideration and decision making should be done here in public setting rather than a private setting.
Appreciate the reminder. Okay. Through the process part of it, why don't we go into the next piece, Vishal?
Thank you. So before we launch, next slide, please. Before we launch into the spending target recommendation, I want to recap some data on affordability challenges in California. So I've shown this before you many times, as well as other bodies like the advisory committee. This figure shows average healthcare spending growing from about $2,700 in 1991 to $10,300 per capita in 2020, translating to a 4.8% average annual growth rate during that 30-year period. Next slide. And this slide shows average annual employer-sponsored premiums. Because premium trend data for California only goes back to 2013, we show national data here. The trend for California is similar. In 2023, the average annual premium for employer-sponsored family coverage was approximately $24,000 and approximately $8,400 for single coverage. Some have compared the cost burden of family premiums as equivalent to a family purchasing a Toyota Corolla compact car each year. And it's not just premiums that have increased dramatically. Part of the cost shifting to consumers is through plans with higher and higher deductibles. Here we see the growth of family deductibles, which have quadrupled in the past 2 decades. Employers with less than 50 employees, indicated by the yellow line, saw a 10% annual growth rate. And then the rate for employers with less 50 employees or more also saw a similar rate of 9%. Next slide. So I talked about the increases we're seeing in premiums and cost sharing, and I also want to talk about the human toll. A 2013 survey commissioned by the California Healthcare Foundation found that more than half of Californians and more than 2/3 of those with lower incomes, defined as under 200% of the poverty line, reported skipping or delaying at least one kind of healthcare service due to cost in the past 12 months. Among those who reported skipping or delaying care due to cost, about half report that their conditions worsened as a result. Next slide. So this figure shows that the high cost of healthcare disproportionately affects Black and Latino Californians, of which respectively 36% and 40% report that they had problems or were unable to pay medical bills. In contrast, only 20% of white Californians report these concerns. Next slide. So Black and Latinx consumers are also more likely to report that they or a family member skipped care because of cost, as shown in the orange and gray bars. And moving on to the next slide. Having kind of gone over some of those sobering numbers about the high cost of healthcare, I now turn to what the literature says about opportunities for savings in our healthcare system. As many of you know, there was a landmark report by the Institute of Medicine in 2020. In the report, they identify 6 waste domains. They're listed here on this slide. For example, failure of care delivery, overtreatment, pricing failures. Research by Schrank and colleagues examined these 6 waste domains, concluding that implementation of effective measures to eliminate waste represents an opportunity to reduce the continued increases in U.S. healthcare expenditures. They estimate that approximately 25% of national healthcare spending is wasteful or inefficient. We do want to know, and the authors note, that interventions can reduce wasteful spending, but it can't be wholly eliminated. There's an example listed here in the sub-bullet of 102 to 166 billion identified as estimated waste due to failures of care delivery, and about 44 to 97 billion could be reduced through effective interventions. The waste domain of pricing failures in particular has driven commercial market spending growth. One study in 2019 found that hospital prices for routine services, such as joint replacements and MRI scans, varied by a factor of more than 5 within major US cities. And then, just as we spoke about earlier with regard to other states with spending target programs, they've done cost driver analyses, and price growth has consistently been the reason for high commercial spending growth. Next slide. And now I'll transition to OCA's recommendation for the healthcare spending target. So CJ just covered this, but just as a quick reminder, last Wednesday, OCA posted its recommendation for the proposed spending target. What I'm presenting today is the beginning of this process, and a vote occurs later this spring. Today, we'll also be sharing input from the advisory committee, and you'll discuss our recommendation. This recommendation is similar to the proposal we shared in December, but with some updates. I'd ask that you hold your questions until I go through the full proposal. OCA recommends the adoption of a 3% statewide per capita healthcare spending target for 2025 to 2029. This is based on the average annual rate of change in historical median household income over the 20-year period from 2002 to 2022. I'll now walk through the supporting rationale for our recommendation. Next slide. There are several reasons for why we tie the target to historical median household income growth. First, basing the target on this measure adheres to the statute's requirement to promote the goal of improved consumer affordability. This is also in alignment with the board's preference for using a consumer-centric economic indicator. Most importantly, tying to historical median household income growth signals that healthcare spending should not grow faster than the income of California's families. Additional rationale for our recommendation is that a single economic indicator is simpler to publicly communicate and understand rather than a blended indicator approach. The recommendation is also to use a flat average annual percent change in median household income growth to avoid concerns about decisions on how to weight or adjust distinct time periods within the 20 years. Lastly, a 20-year average of historical data reflects long-term patterns and does not rely upon uncertain forecasting. Next slide. OCA recommends not applying adjustments to the target. With respect to adjustments, we examined population-based measures and technology-related factors. In October, we discussed adjustments based on population-based measures for age, sex, disability status, and prevalence of chronic conditions. We found that the adjustments appear to be small and correlated with one another and potentially other economic indicators. There is also limited data available to forecast the impact of some population-based indicators on future spending growth. For technology-related factors, as we discussed earlier, OCA would need to predict the net impact of new technology on healthcare spending in advance of market entry. This is because the target is set in advance of the performance year. Further, broadly applying a technology adjustment would also assume equal rates of adoption across all healthcare entities, which is not consistent with practice and the literature. Rather than making prospective adjustments for uncertain technology impacts, other states provide context for drivers of spending when reporting unusual or infrequent events that have an outsized impact on spending growth. For example, the introduction of Sovaldi, as we discussed earlier, to treat hepatitis C caused many healthcare entities in Massachusetts to exceed the target. Similarly, OCA would also take into consideration specific facts, such as market-wide events, when deciding whether enforcement is appropriate for entities that exceed the target. Next slide. I'll now cover OCA's recommendation on revisiting the target. Under the statute, the board has the authority to revisit the target, to update it periodically and consider any relevant adjustment factors. OCA's recommendation is for the board to consider changes to the target in the event of extraordinary circumstances. This could include highly significant changes in the economy or the healthcare system. OCA recommends that the board meet annually to consider whether any needed updates need to occur for the target, including adjustments for unforeseen circumstances. And this concludes my walkthrough of our recommendation, and I'll turn it back to the chair to facilitate discussion.
Great. I'm going to start. I'm sure everybody wants to make a comment. I'm going to go this way. Ian, we're going to start with you. Oh.
We want to talk about advisory committee feedback first. Very good.
Yes, helpful. Thank you.
Appropriately.
Yeah, so we discussed this yesterday with the advisory committee. There was, try to summarize half an hour's worth of comments into a few sound bites, but generally speaking, there was broad-based support from many of the individuals for the 3% target. There was some, as alluded to earlier, some discussion that future targets may need to be downward adjusted for various factors or indicators, including but not limited to technology. There was also some discontent with 3%, though not a firm proposal or number put out as an alternative. One of the suggestions that we also discussed earlier in the realm of technology had to do with visiting or evaluating the trend in the cost of specialty drugs and potentially adjusting the target for the cost of specialty drugs. I'd also want to ask Board Member Lewis if there was other pertinent feedback or comments that you think that I'm overlooking related to the advisory committee's reaction to the spending target proposal.
Yeah, that was actually why I raised my hand. I think you did a good job capturing it all. There were two things that stood out to me that seemed germane here. One was alluded to in public comment. A number of providers on the advisory committee very explicitly talked about increased acuity that they're seeing as a result of affordability challenges. There was the ER physician that Beth Capel referenced. There was also a county-based behavioral health care provider who spoke directly to that. And then the other thing that was notable to me that was an interest among several people, at least four, maybe more, in accelerating the timeline that we consider sectoral definitions and targets. That came up particularly in the discussion around technology and specialty drugs and the differential effects that increases or decreases in spend due to technology might have across different sectors in healthcare, as well as the context of what we're contemplating here, a 5-year target, and the utility of having sectors defined as we go into a 5-year period like that.
Okay, helpful. I'm going to helpful update. I feel like you presented a summary, augmented the summary from the advisory committee. Starting with you, any other reactions or questions, comments about what Vishal just presented? I think in many ways, some of it is a representation, but supported by some of the work and things that have guided the discussion to date. Not to put you on the spot, Ian, but want to give everybody the mic on this one, so because it's so important.
Yeah, thank you. I mean, you won't be shocked. I'm a believer that prices are too high as they are right now, but I'm also very sensitive to making sure that we act deliberately here. I think staff have done an incredible job so far, and I'm feeling very confident going into this public comment period about kind of where the direction we're heading.
Elizabeth, to you next.
Thank you. First, I had a question. It was for either staff or for Ian about the advisory committee. Did anyone, particularly on the provider side, have ideas for how to reduce costs or what would achieve affordability, like more investment in primary care or use of, social worker? Any ideas on how to achieve the goal? Did that come out of the conversation?
Later in the agenda, we had two presenters, and you'll be hearing from them today, one on doulas and one on Anthem's doula program, and then Sharper Steely's coordinated care model. So that was well received by the advisory committee, and how do we kind of expand these models, and as part of kind of slowing spending growth, and then I think for the target itself, I think some of the providers spoke to kind of going back to the sector targets. Some of them did raise kind of more individual kind of look at what their costs are and setting a sector target. But the affordability kind of conversation about ideas from providers is more part of the cost reducing strategies portion of the agenda.
Thank you. And I think it's actually encouraging. I think there is growing evidence about what could make a significant dent in costs through expanded primary care. And to Beth's earlier point, as if this is a package, there's a real opportunity to reduce total spending. So, and in terms of sort of the current target, I really appreciate the staff's work. I think it's very robust and evidence-based. I'm not convinced 3% achieves the goal of affordability. So I don't know if you've looked at what 3% growth year over year does to affordability. Is there an analysis of that?
So this recommendation would, you know, since we're basing it on median household income growth, it's about growing no faster. Healthcare spending should grow no faster than household income growth.
Certainly doesn't reduce any costs, though.
Healthcare costs would still grow, just at a slower rate.
And we can show the data of what the 3% does. I think that for the next meeting.
I mean, I just, because it's a point of clarification, and apologies, I'll turn it back over in a second, but I think it's just flat. If your spending growth target is the same as the growth of wages, affordability is going to get no better and no worse. It's not an actual improvement in affordability, but it also, the problem doesn't get worse. Am I missing something?
Well, we also have to acknowledge that we don't know where the spending will be and how it will or won't be passed on to consumers. So we understand it's an inexact science in that regard.
But so co-pays and cost sharing could change, but cost sharing could change regardless. I mean, that's an unknown variable. But generally speaking, correct me if I'm wrong, we're assuming here that if we set the spending growth target at the same rate as wage growth, we're not going to make healthcare more affordable. We're just not going to it's not going to be less affordable over time.
You're starting from two different bases, though, right? Income is starting at a higher number, so 3% growth of median income is going to grow at a larger absolute value than 3% of a smaller number. Let's say that it's 10,000 per capita. So it does change. They don't track in perfect parallel as a percent of total.
And that's, I think I got some of that. So it's going to get better or worse relative to wages?
Better. So as a share
at 3%.
Assuming that they both continue to grow as projected.
I think we're not clear about what we mean by affordability here. I mean, CJ is right that if you're making $60,000 and it grows at 3%, you have $1,800 more. If your healthcare spending was $20,000 and it grows at 3%, it's $600 more. Is it any more or less affordable? Depends on how you define affordability.
I do think your point, though, Don, if we take away all of the important but sort of noisy nuances, you're right. 3%, they track very similarly. It's not like we saw 3% growth in incomes and only 2% growth in healthcare costs, and that sort of creates a more sort of poignant change. So I think it is an important clarification. Okay, I want to return, Elizabeth. You never officially gave up the mic, so take it back.
Actually, we had very similar perspectives and questions, and I'd like to aim a little higher in terms of making a dent in affordability.
Got it. Yeah, good. Ian, I'm going to come back to you after we go around. I mean, the person with the last word will keep, I mean, it's a circle here. All right, Don, anything more you want to add before I?
Just a handful of points that I jotted down when I was looking through this. So I do think fundamentally it makes sense to think about this in terms of wages, because our charge here is is largely to look at affordability, and so that is relevant, or I guess a better marker than other markers that we've contemplated so far. 3% is what other states have been doing by and large. None of them have fallen into the ocean or collapsed into the center of the earth if they're landlocked states. And part of the reason is that there's, and we don't talk about this a ton, but there's a good amount of fungibility written into this. And if we start at a target and we find that we've missed the mark, this board is presumably meeting on a regular basis on going forward. And so we have the ability to adjust. I appreciate that Massachusetts came down in their spending target. Just having lived around these circles that we all work in, that's much, much less common than the opposite. So I do think if we start higher, it's much more difficult to come down than the other way around. The pressure is not going to be in that direction. It's generally not in that direction. The other thing that I just wanted to flag, Integrated Healthcare Association sent out this nifty analysis using their Atlas data that showed that integrated care, so capitated models, are coming in about 3% right now anyway. It's a non-integrated care that is significantly higher than that. So what that says to me is that there is a pretty straightforward path here. Part of what we're trying to look at is pushing models of care that are higher quality and lower cost. And we've already got an example in nature of how this happens. And that's really important because what it tells us is that there's a way. So those are just additional comments.
I'll share mine at the very end. But Sandra, you go first.
So I would, I appreciate all the comments about both learning from other states, understanding what they've done. I appreciate what the ongoing pressures will be. I think staff has done a really good job. I'm very supportive of simple, easy to explain target based on wages for all the reasons that we've talked about in terms of affordability. I think there's a tremendous amount of administrative waste. We have products that we know provide better outcomes clinically, and yet we have a lot of products that don't provide that and that are ridiculously expensive. I personally think that AI is here. There isn't going to be a regulatory anything that says, yes, this works or yes, it doesn't. AI is here. I have skepticism on the clinical side, but I have great optimism on the administrative side. And I think one of the things that people struggle with in our system now is the complexity to get what they're entitled to. And so administrative simplicity and administrative cost waste are things we should absolutely push on. And I think 3% is a reasonable place to start. And I would be interested in this board reviewing that more than annually to really understand the geographic differences that exist in the state, to Dr. Pan's point. And so I don't know that we'd look at that annually. And yeah, we'll get pushed and maybe we come back and say 3% was too high to actually meet our affordability goals. And I think this board should be open to that.
Thanks, Rick.
Thanks. I agree with my colleagues that basing the target on median income growth is a good idea. As I said earlier, think that a more likely estimate of median income growth in the next 5 years would be an estimate based on the last 10 years and not the last 20 years. I am also concerned about the ability, and Richard raised this earlier, the ability of the board and the office to use the main lever that it's got, which is to say that the covered entities that spend or that receive revenue above their target would have to repay the extra revenue to the state. I'm concerned that at a 3% target, there would be hardly any covered entities achieving that. And Don just mentioned the IHA analysis. I've not looked at the most recent IHA analysis. You know, Don, you are painfully aware of the Kaiser rate increases in 2024, as are, you know, anybody else on the employer side. I do think that we are in a entering a somewhat different kind of spending growth trajectory than we have been in for the last decade. That from 2010 through 2019, health spending growth nationwide and in Western Europe, most of Western Europe was at historically low rates. And the 3% targets that other states have adopted mostly were adopted during that time frame of really low spending growth. And the concern I have about a 3% target is that hardly anybody will meet it, and that will make it very difficult for the board or for the office to say to basically every health system in the state, you know, you didn't meet your target, you have to pay money back. And I don't know whether, you know, if the target were 4%, I can't promise that there'd be significantly more systems that would meet that target, but it seems more likely that at 4%, there would be more systems that would meet the target, and then it would be more possible to say to the systems that didn't, you know, your colleagues, your neighbors did this, and why didn't you? And actually have some, you know, be able to impose some penalty there. So my concern about the 3% target, it comes from two directions. One, if we are trying to base this on estimated median income growth, my guess would be that estimated median income growth is going to be greater than 3%. I mean, 10 years is arbitrary, 20 years is arbitrary. But, you know, looking at the graphs that we looked at earlier, just kind of, you know, you don't need to be a statistician to kind of say, well, what's most likely for the next 5 years? And I think most likely for the next 5 years is something closer to 4%. But then independent of that, the other side of this is, you know, is the target a target that is likely to be achieved by any significant number of covered entities? And we haven't talked about what covered entities are. I use the word health systems. I'm assuming that, as in other states, sort of medical groups and or health systems would be responsible for meeting the target, and that very few of them likely would at 3%, which would make it difficult to establish, you know, the legitimacy of the operation. Because to do that, I think eventually the office will need to be able to say to some number of entities, you overspent the target, you owe money back. And, like, you know, I've said it 4 times just to repeat, I think that will be hard to do if the target is 3%.
Okay, appreciate the input. Richard, your turn.
Thank you. I have to admit, I do have a lot of concerns with what's being proposed. You know, when people evaluated the Massachusetts Commission and its success, what seemed to be the bottom line, and for a lot of the people in doing the evaluation, whether you consider it success or not, is that basically the commission had widespread credibility amongst people. What I'm concerned is we're not heading that direction. We want to base it, so we want to base it on median. I think we have a reasonable rationale, although one could argue how connected they are with, you know, actual demand for healthcare, but our need for healthcare. Actually, I'm going to get back to demand and need. But even looking at the graph, right, and we sort of picked 20, but why 20? Why? And the reason I asked for a 5-year rolling average because that sort of smooths it out. And then we can look at, and in fact, I did, and so what you saw is actually the last essentially almost decade, it's at a higher level. So if that's our rationale, well, we're not really sticking to that rationale. The other part is that even in this presentations here to the board, we admit technology is a driver of healthcare costs, yet we're not making an adjustment for that. We admit that population, now you said small, but compound interest, right? Small added up and it becomes big. And we have an aging population, right? So fine. If it's small, then it's small, put it in there. Like, what's the problem, right? So so we discuss it and we say, well, we recognize this is, but yet we then say, well, but we're not going to put it in adjustment in there. I mean, we can project our demographics. Yes, you know, but I mean, that's what we do every time. Finance, I mean, we have a 5-year projection. Finance does that, LAO does that, federal government does that, you know, census, et cetera. So I think it's disingenuous to say we can't project into the future. Certainly demographics we can adjust into the future, okay? And most of those predictions are, you know, pretty on mark for most part, you know. So why don't we do that? I don't understand. The excuse is it's small. Well, then it's small, put in whatever it is. That adds credibility because it's a fact. It's real. People can look and, you know, so I don't know why we didn't do that. The other part that also I think that's going to be the other thing that I think we also need to figure out how to factor in is that, you know, we do look at and we say, okay, healthcare entities, you're the ones driving up the cost, et cetera. But we also have to think about choices consumers make. Right? Because we just heard about, oh, we have all this waste. I appreciate, you know, I had a conversation with your predecessor, Secretary Ghali, Secretary Dooley, because we've had this conversations, and she says, yeah, everyone says we have, but no one can find it. No one can, not all of it, but basically, you know, when you start drilling down, you go, well, what do you do? So, for example, I'm a pediatrician. I say no when people want antibiotics for colds, but they get really upset about it. What do I do, right? By the way, my compensation is tied to patient satisfaction. So, right, that's a quality measure, right? So what do I do, right? I say no, and I try to teach my residents say no, but it's really hard, okay? And there's a lot of gray stuff, okay? So what is that 20? So there's lots of studies that says, oh, look at all this, quote, waste. And I'm not saying there isn't waste. There is waste, you know, and I appreciate the conversation about, I think there's a lot of administrative waste. And hopefully AI can straighten that out. I'd like to see some actual evidence papers of that. So, okay, that'd be great. I'm not saying AI is useless, but I'm just saying that I'm a little more skeptical about AI's success and ability. By the way, we have AI, I guess AI did successfully help, is it Cigna or I forget which health plan, reject legitimate claims from oncologists for cancer care. They used AI processes. I guess that saved money, but that's not, I think, what patients want. Right? Because of what that meant if they didn't get care. Right? So I think but we do need to factor in, talk about, I don't even call it waste or not, but the alternative medicine market is worth in the U.S., in the U.S. is about $120 billion. Is that waste or not? On evidence-based treatment care. People are spending out of their own pocket, actually. They chose to do that. And the other thing I think we need to recognize is that not everyone always, yes, people are lower income, right? They have fewer choices, but if we're looking at the overall healthcare spend, there are a lot of people getting stuff that things like whole body MRIs. Well, frankly, that's wasteful. But what happens when someone sees something and says, oh, by the way, go see your doctor and get that worked out. And then now I get, oh, well, someone got a whole body MRI and they have something I don't know. Is that wasteful when I now have to follow up on that? Okay. So, I do think that, as we're looking at this and, yes, we have to pick a cost target and so forth, that we have to also think about what is driving. And some of that is actually consumer driving, right? There's a whole phase when they thought that actually having a bone marrow transplant for breast cancer would be helpful. And there were all sorts of news stories about why health plans were denying that and so forth. Turned out it wasn't so helpful, but it's pretty expensive. And there was a lot of public pressure to get that done. Is that wasteful or not? So I think we need to take account of that. The other thing is I do agree with Dr. Kornick. What he said is that if we set a level in which most people can't or won't achieve, that may raise some credibility issues as well. Okay. And also, of course, that's additional work for the for the agency. That's fine. You guys work hard. I don't mind giving you more work, but you know, coming up with these plans. But that's also why I said is that okay, we're going to come up with whatever target we come up with, but we also need to set ground rules for okay, if you go over the target, how will we look at how you went over the target? And it can't be arbitrary. There can't be any, you know, it can't seem to be arbitrary. It had so in addition to we have a methodology, which I think, you know, again, we have to, that methodology have the credibility with people. We also, and then we'll have a target. We also need to set what the rules are, especially if part of what our goal is. Seems like the staff's recommending this, is that we set a target so low that we're going to have a lot of people who are going to go over and have to go to the agency and justify why they're over the target, and then it's going to have to be clear that what you're doing with everybody, right? Your plan, adjustment plan, et cetera, you know, is done in a non-arbitrary, fair manner with people, right? And so so I think that's something to think about in terms of, again, credibility. The other thing I also want to say is, while I don't object overall in the long term for a 5-year, I do wonder, because, you know, the statute said the first year is a goal and then we enforce, but essentially if we do a 5-year, we're doing 4 years enforceable goals. And part of the reason in the discussions for having the first year is to actually learn. And so whether we really should do 5 years on the outset, right, and try to bake that in somewhere. And I do agree that we're going to go back and revisit, et cetera, but maybe instead of 4 or 5 years out, we say, okay, well, we're going to take a few years, learn, and then we'll, based on that learning, I mean, we were trying to learn from other states, but we're kind of different in some ways too, that perhaps it makes more sense to say, let's do a few years, learn, and then say, okay, based on that learning, we're going to build it out farther, right? So, and that also provides more predictability and so forth. So, I mean, there's a lot of advantages to doing it for a few years, but I do wonder whether the outset makes the most sense for us, because it's, you know, it gets sometimes, you know, adjustments sometimes can be a little harder as you're rolling out and so forth. So, so I want to put that on the table to consider, and then which case, you know, we see how that works, we see the next year, and then we say, okay, now we have a better sense of where things are, and then we can build it out for, you know, and at the end of that period, or even before the end of that period. Thank you.
Great. I know a ton of very rich feedback. Didn't expect anything less. I'll just add a few comments, and then I think we want to move to some public comment. We'll have a chance to be able to come back. Oh, Ian, I promised you would get in. Let's do that first. Yeah, go for it.
Very quick. I just wanted to point, Don mentioned that other states are generally coming in at around 3% in the next few years. I wanted to flag that there's a slide right at the very end of the slide deck, which I don't think will be put up here. It's in the appendix, but it details that out and shows where the other states are, particularly Oregon and Washington, our neighbors to the north, around 3%.
And we've seen that they've shared that publicly in prior meetings, which I appreciate. I think just to comment on credibility, you know, and if a number of systems and covered entities don't meet the target, part of the reason why I'm interested in sort of the market dynamics, the models, is because maybe there's a theme for why they don't meet it, and it's because of a chosen model that's tried and true and built into what they've done for years and decades that should be challenged in the collective. So, you know, I've struggled with that point quite a bit, because I do think it's an important one, and we don't want to set this body up really you know, smart, hardworking, experienced folks, including the input from the advisory committee and the public, to do something that doesn't make sense. But I am less afraid personally, and when I think about it, that because a number don't hit the target or meet it, that that's a symbol that we've chosen the wrong one. It might actually mean that we need to look more closely at what some of those underlying models are. That's why I'm interested in Massachusetts experience, who maybe hasn't hit those targets, are there some themes and unifying characteristics of those systems that we should be aware of ahead of time as we look. And then I know it's been raised, but I want to remind us, whether we pick 5 years or 1 year, this is going to be an active conversation that we will learn from. And I know it says annually we will meet to discuss this. I can imagine that we're going to wait 12 months. I'm sure that somebody here will say each month, let's revisit it and let's have that conversation at least for a while. And we're going to create that kind of space here. So I think that's really important. And the last point I will make, I'll add my sort of real acknowledgement of the staff's effort in putting this together and thinking through it. And yeah, it's a little bit uncertain. Are we pushing pretty hard and far with 3%? And should we be somewhere else? Or are we not pushing hard enough? Because affordability seems at best to be not improved, maybe not worsened, but not improved. And part of this objective is to make sure that we do all we can for the consumers who shoulder this in California. So appreciate the conversation. We are clearly not ready to take a vote today. Thank God we don't have to. And appreciate now a chance to hear from the public and their input on both what's been presented and then the conversation by the board. So let's go to public comment if we can.
We now welcome public comment. We'll begin with an individual who will come to the podium here in this room, and we will toggle back and forth between the physical room here and virtual hands raised for those members of the public who are attending virtually. And we will begin now. Thanks so much.
Members of the board, staff, public, I'm Steve McDougall. I'm not only a union leader with the CFT, I'm the president of the Municipalities, Colleges, and Schools Insurance Group, Joint Powers Authority, headquartered in Salinas, Monterey County, California. I don't know what a Corolla costs. I never will know. My dad worked 40 years for General Motors and was a leader of UAW. I'm never going to buy one. However, all jocularity aside, that's a MASH reference, Father Mulcahy. I'm showing my age. I do know what it costs for our richest, least cost share plan in MCSIG, and I know what our cheapest one that carves out the hospitals in Monterey County costs annually. The richest plan, $36,000 a year is what it costs, some of which employers pay, the difference the employee pays. The cheapest plan that carves out the hospitals in Monterey County is almost $22,000 a year, $52 short actually. I wish we had $10,000. I wish we had $15,000 on that one graphic we saw earlier, but we don't. And what that means for the folks that participate in our plan, the educators and other public employees, it means they have less take-home income for the privilege of these plans. For those who are in defined contribution plans for their pensions, and all of them are, that's less contributions to their pension and less pension payouts for the rest of their lives once they go out to pasture. And for those that are in CalSTRS, they don't participate in Social Security at all. So, I don't know what a Corolla cost, but I know what this cost, and it's not sustainable. And when I heard yesterday that from one association, and I heard from one committee member that household median income is not relevant, I think it is. I just gave you evidence why. Thank you for your time.
Thank you. Now we'll turn to members of the public attending virtually, and we see Sarah Buabipsa. We invite you now to unmute on your end, please. Sarah Buabipsa, we've unmuted you on our end. You'll need to unmute on your end. Please go ahead. Okay, then we'll move to the next person virtually, Harvey McKeon. We are unmuting you now and we invite you to unmute. Please go ahead.
Hello, my name is Harvey McKeon. I'm calling from the Carpenters Union. We support this 3% target. Already, we are seeing companies raising premiums in potential anticipation of knowing that there's going to be these caps. And reacting to some of today and yesterday's discussion, I heard a presenter say that in other states, spending targets have energized policy discussions in other areas, and I'm hopeful that this can be the case. For example, I think this point was made reacting to a concern that the cost of pharmaceuticals was growing at a particularly fast rate for providers. And it's true that profit margins of pharmaceutical companies in the S&P 500, for example, were 76.5% between 2000 and 2018. And the pushing of expensive drugs is surely part of that story. In our own rate renewal this year, we saw a drug under investigation by the feds for being overly pushed, also coincidentally being our group's highest net claim drug. I've also heard concerns generally from committee members yesterday in the discussion squarely about this 3% figure and that really this should be higher. It shouldn't be connected to median household income growth. Well, to put that criticism in context, even the higher 4% figure still wouldn't be as much as the growth of executive compensation among hospital and health system executives. The median increase in their salaries was 5% in 2023 alone. And that is 5% often on top of what is already millions. So again, maybe another area where policy discussion can eventually be energized via this spending target implementation. So to conclude, the Carpenters support the 3% growth target, and we look forward to outlining our views further to OCA in a comment letter. Thank you.
Thank you. Turning to individuals in this room, please step up to the podium.
Hi there, Carrie Sanders with the California Pan-Ethnic Health Network. I serve on the OCA Investment and Payment Work Group, so I'm really happy to be here today. We fully support OCA. I need my glasses, actually, sorry. We fully support OCA basing the target on median household income and think 3% is the least we can do. As board member Mitchell and Moulds both noted, 3% is not going to make healthcare more affordable. It simply keeps it from becoming even more unaffordable. Appreciate the concerns that others have raised about the target being too low, but access is inequitable today. And the primary factor driving access and inequitable access is cost. CPAN has worked alongside many others in this room to increase access to healthcare coverage, including making Care and Cover California more affordable through better subsidies. But as we know, health insurance does not equal or equate healthcare access. I really want to thank OCA for the incredible research that you shared on today, comparing spending growth to changes in median household income. I appreciate that we need to get, the methodology, good, but the perfect should not be the enemy of moving forward. This is not an academic exercise for the folks that we represent. We have folks who are on the phone line, on the call right now, who want to share their stories. But I would simply say that in the past year, expenses have tripled with inflation. After COVID, everything is expensive. Housing, gas, the cost of gas alone for a week is $300 for a person who's commuting. We have to keep healthcare affordable so people are not having to choose between housing, food, other necessities, and the healthcare that they need. The most important thing we can do is actually to improve the system. And to board member Pan's comments, this is where population health matters. Let's figure out how we change the incentives in our healthcare system to more adequately fund prevention so that fewer people can die from preventable conditions, and we can move to a system where primary care is adequately funded the way it should be. We also support the recommendation not to make population adjustments at this time. We disagree with comments about raising the targets. We hope that we'll actually be able to look with the change in the system at further downward adjustments in order to really fund where we need to fund the system where we need it. We strongly urge you to support OCA's recommendation today, which will put us on the path to more equitable, affordable care. Thank you.
Thank you. And we do appreciate everyone trying to keep their comments to 2 minutes or less to get through all these individuals who wish to speak. And so now we'll turn to virtual attendees. Kelly Brooks Lindsay, we've unmuted on our end. Please go ahead and unmute.
Good morning, this is Kelly Brooks. I'm with the California Association of Public Hospitals and Health Systems. Public healthcare systems strongly support improving affordability for patients and consumers. However, we are concerned with OCA's initial spending target proposal of 3% and the potential detrimental impacts it could have on patients and access to care. We would also strongly urge for further considerations related to Medi-Cal. Public healthcare systems provide 35% of all Medi-Cal and uninsured hospital care statewide. Imposing this target in Medi-Cal implies that baseline spending is adequate to begin with, but Medi-Cal reimbursement is nowhere close to covering the cost to provide care, and this must be taken into account. For example, public healthcare systems are currently undertaking efforts to address a long-standing structural deficit in Medi-Cal financing that is more than $3 billion. We are working to increase our base rates, developing strategies to try to contain costs as much as possible, and we'll be working to secure other funding sources to stabilize our financing. However, the spending targets must account for the historical underfunding of the safety net and shouldn't penalize providers as they work to try to correct those issues and right-size payments. Further, Medi-Cal financing is complex, and there are a number of outstanding questions on the spending data that will be collected from DHCS and at some future point from the managed care plans, including provider self-financing, attribution, and supplemental payments, and how these will be treated in OCA's total healthcare expenditure analysis. For these reasons, we urge OCA and the board to consider adopting a more realistic and attainable spending target and to limit it to an initial 1-year cycle rather than the current proposal of 5 years to allow us more time to work on this. Setting an initial 1-year target will allow for more deliberation on these issues and time to further develop a methodology that takes all of this into consideration. Should the board decide on a longer time frame, we strongly recommend the target be phased in so that providers have sufficient time to prepare for meeting it and to not risk jeopardizing care for patients. Thank you.
Thank you. And here in the room, please go ahead.
Good morning, everyone. Stacey Uranta, CEO, Sharpers Daily Medical Centers in sunny San Diego, and I'm commenting on behalf of Sharpers Daily. I believe that the spending target of 3% is a concern because we have gone through a significant pandemic, and our trend rate for the last probably 8 to 10 years has been in low single digits. However, COVID took a real beating on us, and our staffing expense has gone up well above that trend. Our pharmaceutical costs have increased 30% since 2019. We are looking at the minimum wage, which includes compression. We have specialty pharmacy that's exponentially increasing. And so I think looking at a trend instead of a 20-year trend, looking at something less really ties into what we're experiencing as providers. We want to do the right thing, and you'll hear about our organization later. Thank you.
Thank you. Looking online, we're turning to Ryan Spencer. We invite you to unmute.
Members of Ryan Spencer. I'm a legislative advocate for several physician and provider associations, including the American College of OBGYNs, California Society of Pathologists, California Radiological Society, and the California Podiatric Medical Association, all sympathetic to the cost of healthcare. However, in my discussions, there's been a general concern that the proposed statewide spending target of 3% was chosen really more for simplicity and doesn't really align with the realities and challenges of accessing healthcare in California. The concern of an arbitrarily low target could actually impede equitable access, which is the exact opposite of what we're trying to do here. In addition to this low target rate, keeping it at 5 years, even with the ability to revisit with qualifiers, seems unnecessarily long, especially given California's inexperience collecting healthcare expenditures. So we hope you take these comments seriously and welcome any questions you may have in the future. Thank you.
Thank you. Here at the podium, please go ahead.
Good morning. Thank you for the opportunity to make some comments. I'm Michael Corpio. I'm the president of the Sacramento Market for Dignity Health, and I am representing my organization, which is a statewide organization. Since 1849, our not-for-profit mission has been to improve the health of the communities we serve. We are the largest provider of Medi-Cal services in California, making up a significant portion of the safety net. 3/4 of all patients come to Dignity have either Medi-Cal or Medicare. Unfortunately, government reimbursement has not kept pace with the rising cost of labor, supply, and drugs, leading to a loss of over $245 million last fiscal year for Dignity. We are deeply concerned that the current proposal will have disproportionate impact on all safety net hospitals. The proposed target falls well below our current lived experience. Hospitals are a critical part of our state's first responders to disaster, and we welcome everyone, regardless of their ability to pay. As we work toward our financial recovery from COVID, Dignity Health and other health systems operating in the red will be penalized under this system. The target must be rooted in rigorous data. The current proposals omit realistic inflation expectations, adjustment for the acuity of our patients, and the need to compete for skilled workers. Most concerning, we believe it will increase healthcare disparities while costing the states billions in economic activity. OCHA must propose a realistic target that aligns with the state's initiatives to create a modern system while addressing the broader social determinants of health. A system-wide focus on health equity can lead to long-term cost savings, but it requires providers who are financially able to make initial investments. Let's work together to ensure that our healthcare system meets the needs of our communities and lays the foundation for a healthier, more equitable future. Thank you very much.
Thank you. Looking online, Mira Morton, we invite you to unmute.
Thank you. Good afternoon, Chair and members. This is Mira Morton with the California Children's Hospital Association. We'll be submitting more comprehensive written comments, but wanted to flag a few items specific to children's hospitals today as you consider the proposed 3% statewide cost target. CCHA is very concerned with the target and locking it in for 5 years specifically. We would align ourselves with broader comments provided in writing by the California Hospital Association and also some comments made by Dr. Pan today. But we are very concerned that this target is particularly unrealistic for tertiary hospitals like children's hospitals who provide care to the sickest children and are the place children all over California go to receive new life-saving therapies like the recently approved cures for beta thalassemia and sickle cell disease. Yesterday at the advisory committee meeting, there was a lengthy discussion about difficulty in trying to set an adjustment to account for specialty drugs due to their unknown impact in future years. But this example highlights the need to let the target be more adaptable in the early years and to include prospective adjustments for foreseeable significant cost drivers, even if we don't know exactly how large their impact will be. At the advisory committee meeting again, and also again here today, several members argued that because the cost of healthcare exceeds what families can afford, this alone is a reason to keep the cost target at 3%. But implicit in these comments is the assumption that if it's growing faster than families can afford, it's due to waste or inefficiency, and that no valuable healthcare or other important spending will need to be reduced to meet this target. Unfortunately, median household income growth does not reflect the growth rate for hospitals' own costs, and this is especially true for children's hospitals for several reasons. For one thing, California's children's hospitals are uniquely and disproportionately dependent on the Medi-Cal program as a payer. On average, 2/3 of California's children's hospital patients are covered by Medi-Cal. Medi-Cal has historically and consistently under-reimbursed children's hospitals for the care they provide. And over the past decade, reimbursement to children's hospitals has remained flat or been reduced in spite of inflation and other costs. As a result, our members have already spent the last 10 years struggling to find ways to cut costs and operate as efficiently as possible, leaving them with little to cut back on in the face of a 3% target. Second, the target proposal includes no adjustment for acuity, except perhaps for age and gender. And ironically, an age adjustment would actually penalize children's hospitals because on a population-wide basis, children use less healthcare resources than the elderly, but the pediatric population served in a children's hospital is significantly more acute than the population in a typical community hospital. In other words, an age adjustment would lead OCA to expect our hospitals to be less costly than average, whereas our population will actually be more costly than average due to their overall acuity. Third, the cost target does not include an adjustment for technology, particularly for new gene and cell therapies. We are appreciative of Dr. Pan's comments and the urgency he raised around the need to explore the impact of these therapies on hospitals' ability to hit the target. Just yesterday, one of our members, a qualified treatment center for several new gene and cell therapies, told us that if in 2025 they are able to treat all of the medically eligible children with conditions like sickle cell disease, beta thalassemia, and spinal muscular atrophy, using the newest curative therapies, their hospital's pharmacy spend would grow by over 60% in 1 year. Without a clear statement from OCA about its values in this area, the hospital must decide whether they should instead serve fewer children to limit the hospital's cost growth, or gamble that OCA will not retrospectively penalize them for providing these life-saving treatments to as many children as are eligible in spite of the cap. Finally, it's important to note that over the past several years, particularly since the pandemic, community hospitals across the country have been reducing pediatric lines of service because they are so costly to maintain. If OCA adopts an unrealistically low target, we expect this trend to accelerate, which will in turn mean that children's hospitals will be asked to serve even more high-cost patients than they currently do. The patients treated in children's hospitals are, in effect, an adverse risk pool and are likely to become even more so over time. We look forward to working with OCA and the board to make sure that the unique mission of children's hospitals is taken into account in setting and enforcing statewide and future subsector targets on our members, but also strongly encourage the board to consider making prospective policy decisions and adjustments related to acuity and new technologies and the Medicaid population as they relate to children's hospitals so that our members can have clear guidance on how to proceed and plan. Thank you.
Thank you. And if we could keep our comments to 2 minutes or less, we'd very much appreciate it. And now turning to the podium, please go ahead.
Hi, everybody. Ben Johnson from the California Hospital Association. California's hospitals do look to stand with the Office of Healthcare Affordability with the goal of improving consumer affordability, but while also protecting access to high quality and equitable care. And we're concerned that OCA staff's final proposed statewide spending target misses the mark, failing to strike a balance between promoting affordability and maintaining that access to high quality and equitable care. We believe a sudden 40% drop in allowable growth in revenue would have significant negative impacts for California's patients. And we believe the methodology ignores external factors that are likely to influence healthcare costs going forward, like inflation as well as California's aging population. For example, we've previously shared that this target actually comes in half a percentage point below what the state's independent legislative analyst office projects economy-wide inflation to be over the next several years, placing providers in a very difficult position to be able to actually afford the workers and the supplies that they need to care for their patients. In addition, it ignores the significant impact that aging is projected to have on spending in California, with the baby boomer generation entering their 80s or the younger ones just starting to retire now. And data from the Department of Finance and the Centers for Medicare and Medicaid show that this impact on healthcare spending is going to grow at about 0.7% every year, which equates to $3.5 billion, which is not represented in the methodology. And we would respectfully disagree that such an impact is negligible. In addition, we do think that California's proposed target does stand out as an outlier compared to the other states. By and large, almost all the other states had at least phase down factors before reaching somewhere close to the 3% target, in contrast to what California is proposing. And in addition, 7 out of the 8 states proposed or implemented targets in excess of their prior year's performance of their economy in terms of growth, whereas California's would be 2 percentage points lower. And while other states were dealing with general inflation of less than 2% when they set their target, California is currently experiencing inflation of around 4%. So finally, do wish to align with comments from board members regarding the mismatch between setting a target for enforceable years and having no clarity regarding what the enforcement process will actually look like. And in addition, using a historical period for determining median income growth that includes the largest recession in a century. So to fulfill the statutory mandate, we believe OCA needs to present a sounder rationale for why this target would meet the multiple objectives in state law, including by promoting affordability while supporting the ability of California's healthcare system to improve access to world-leading life-saving care. Thank you.
Turning to the online guest, Jen Karamaka, please go ahead and unmute.
Gadwamaka, and I'm with the Cambodian Family Community Center in Orange County. At the community center, I see many cases where community members are so worried about high deductible costs that they avoid going to the doctors for many health issues. And because of this, our community members' health conditions worsen, and they would only seek professional care only when they can no longer withstand the pain. If OCA were to support a 3% spending target, we would see California move towards a path of a more sustainable, affordable, and equitable healthcare system. This would improve affordability for all, and many community members' lives would be improved by not having to skip or delay care due to the anxiety of. So we urge you to stop out of control healthcare costs and vote yes in support of OCA's 3% spending target today. Thank you.
Turning to folks in the room here and at the podium, please go ahead.
Thank you, Secretary Galley and board members. I'm Nick Luizos with the California Association of Health Plans, representing 43 public, private, nonprofit health plans, delivering coverage to over 28 million Californians. And I'll be brief. We submitted more specific comments on the THCE proposal, and I'll discuss that more later. But because it's intertwined at least somewhat with the spending targets, we just wanted to make the point that this is very important work, focusing on the underlying drivers of healthcare costs, but it's work that should not be rushed. We see critical issues that have yet to be resolved with the data submission component of this broader project. And without additional clarity around the data submission and collection process, adopting a 3% spending target needs very careful deliberation. We believe that sufficient time needs to be given to the development of the spending target, and that the board should work closely with all stakeholders with enough time for input, particularly those that will be subject to the spending target. So thus we would suggest that adopting a spending target at the March board meeting, which would be the earliest that we can see based on the timeline, would be far too premature, for instance. So thank you, and I'll address the THC feedback later. Thank you.
Thank you so much for keeping your comments brief. And we also want to remind folks that you can provide written comment as well at oca@hchi.ca.gov. And now we'll turn to a virtual member, Tim Madden. We invite you to unmute. Tim Madden on your end, if you could unmute, please. Okay, then we'll turn to the next virtual member of the public, Steve Shortell. We invite you to unmute.
I'm Professor Emeritus of Health Policy and Management at UC Berkeley. And I think earlier there was some comments about what can we learn from the experience in other states to give us, kind of a sense of what we might expect here in California. One comment was about market competition, and generally where there are more competitive markets, more likelihood to be able to reach the spending target. That I think is true. Very quickly, there are 3 or 4 other items that could be analyzed in other states as well. Examples are the percent. Look at the percent of enrollees that get their care from accountable care organizations. Those data are available, or related value-based kinds of programs. Also, basically looking at risk-adjusted prospective payments. Low value care, hospital compare data is available, can be looked at as well. And the percent of primary care spend may be more difficult to look at in the other states, but I think they're beginning to generate that data. All would point to a greater ability to reach the 3% target. Regarding that target, based on research we've done with a number of the medical groups and systems here in California, it's time to challenge them. Many of them want to be challenged. They won't say that publicly. Obviously, 4% gives them more room to, et cetera. There's a lot of waste that can be eliminated. And my suggestion is to hold the line at 3%. Thank you.
Thank you. Here at the podium, please go ahead.
Good afternoon, Miranda Dietz from the UC Berkeley Labor Center. The worker testimony that we've heard over the last year really highlights the need for this office and the need to center consumer affordability. Yesterday, the Labor Center published a report with data showing the erosion of affordability and job-based coverage over the last 2 decades in California, as staff highlighted earlier. One trend I wanted to add is just the increasing prevalence of deductibles, not just their size. So in 2002, about 1/3 of private sector workers had a deductible in California, according to MEPS. But by 2022, 77% of private sector workers faced a deductible. So even though healthcare spending as a share of GDP has been relatively flat in the last 10 years, this growth in premiums and deductibles has far outpaced the growth in wages and incomes, meaning that healthcare takes up a greater and greater share of family budgets. The worker share of a typical family plan in 2002 was about 4% of median household income. But in 2022, if you include the potential deductible spending that's now a feature of so many plans, a typical family plan is 12% of median household income. We're hopeful that OCA can tackle this problem and make a meaningful difference for California consumers. Our report also specifies some recommendations on the consumer affordability metrics that OCA could track as part of its annual reports. And we're really pleased to see consumer affordability measures on the February work plan. So our report could be found on the UC Berkeley Labor Center website. Thank you.
Virtual attendee Don Shimsky, we invite you to unmute. Don Shinsky, we've unmuted on our end. If you could unmute on yours, please go ahead. Okay, turning to Ellie Mention, we invite you to unmute. Please go ahead.
Thank you so much for the opportunity. Ellie Beanshine on behalf of Sharp Healthcare and our health system in San Diego County. You did hear from my colleague Stacey Haratas earlier from Sharp Steely on the medical group side. And Sharp appreciates the opportunity to comment and share concerns about the growth target proposal and impacts on access to care. OCA has an opportunity to transform California's health system in a very meaningful way, and we support and applaud it. But to do this, OCA's targets and metrics must be grounded in robust data and analysis. And that analysis really must also account for the underlying drivers of healthcare costs and consider negative consequences to patients' access to care and our workforce. Unfortunately, the proposed growth target before you today does not address these important considerations. There are multiple outstanding questions, even those raised by members of the OCA board regarding data analysis and regarding this proposed growth target that have yet to be answered, addressed, or even considered. And we would appreciate the opportunity to have some of that come back before this board. The proposed growth rate of 3% is not only well below standard inflation projections, it fails to account for important and necessary staff investments, patient acuity and health equity needs, inflationary pressures, the rising costs of goods and services, and the state mandates and policies that really do underlie and drive our costs. For instance, Sharp's significant staff investments amount to an average annual wage increase of 6.1% annually over the last 5 years. And this on its own far exceeds the 3% growth target. Setting a 3% growth target would severely impact our staff, limiting Sharp's ability to invest in our workforce and negatively impact the health workforce pipeline. The proposed target also ignores the significant increases in the cost of pharmaceuticals and medical supplies, which hospitals have no control over and consistently exceed 3%. As you heard from Stacey, since 2019, pharmaceutical costs have increased on the Sharp healthcare system by 30% and an average of 7% each year. And while we recognize that pharmaceuticals and medical supplies are outside of OCA's mandate, they simply cannot be disregarded in calculations and projections in healthcare spending. And finally, hospitals across the state are working toward a fast approaching 2030 seismic compliance deadline. Our 4 acute care hospitals are doing just that. And the construction costs have, quite frankly, skyrocketed, and those far exceed 3%. Sharp respectfully request the OCA board reject the 5-year proposal of a 3% growth target and direct staff to return with a proposal that balances these economic factors, underlying cost driver, and fully analyzes impacts on healthcare access. Thank you.
Here at the podium, please go ahead.
Hi, good afternoon. Stacey Whittorf with Planned Parenthood Affiliates of California. PPAC represents California's 7 individual Planned Parenthood affiliates, which collectively operate over 100 health centers across the state, providing roughly 1.2 million annual patient visits a year, about 1 million of which are provided to patients who access care through the Medi-Cal system. As community providers committed to offering high-quality, patient-centered care to all who come through the doors, regardless of their ability to pay, the California Planned Parenthood affiliates are familiar with the impact of rising costs on the ability of Californians to access timely and appropriate care, and frequently serve as their patients' only point of access for healthcare services that might otherwise be unaffordable to them. PPAC appreciates the office's work toward advancing healthcare affordability, as well as the urgency of that task. However, we are concerned that the proposed spending target and the methodology used to arrive at it does not adequately consider the potential impact of new and proposed future investments in the Medi-Cal program on overall healthcare spending. As others have mentioned, these investments are desperately needed to address the impacts of long-term underfunding and to ensure that safety net providers like the Planned Parenthood affiliates can continue to deliver high-quality, timely, affordable care, particularly as their resources are strained in an evolving post-Roe environment. Were the board to approve the spending target as proposed, updating Medi-Cal reimbursement rates to adequately cover providers' costs of delivering care and improve equitable access to care for the 1 in 3 Californians who use Medi-Cal could cause spending to exceed that threshold. Accordingly, PPAC urges the board in adopting its spending target and methodology to further consider the impact of and on Medi-Cal system transformation. I appreciate your time today and look forward to this ongoing work. Thank you.
Thank you. Looking at our virtual attendee, William Barcelona, please go ahead.
We appreciate the discussion today. Bill Barcelona, representing America's physician groups, about 180 risk-bearing physician groups across California, serving 18 million patients. At the present time, a 3% cap based on median family income is not widely understood across the risk-bearing provider community and has been interpreted to mean that contracting trend would be limited to a 3% growth rate during upcoming contract renewals for the next 7 years. Given that the recent contract renewal trends have increased at about 5% over the last few years for capitated providers in the large group commercial health market, there's been confusion and frustration over whether this 3% cap that's being recommended today would translate into a 40% reduction in our members' capitation rates. There is a provision within the Knox-Keene Act, which of course governs how our groups contract with health plans, that health plans have to pay sustainable capitation rates. And there is a history in California from 1998 until about 2002 when sustainable capitation rates were not paid, and over 100 of these risk-bearing groups closed their doors due to insolvency. It is uncertain how these Knox-Keene Act provisions on sustainable capitation rates will mesh with OCA's target cap that's being proposed today. The OCA statute appears to favor a transition from pure fee-for-service payment to providers to alternative payment models like capitation. But it would be ironic if in the adoption of this type of cap at this rate, you would actually undermine the further use of this alternative payment model of capitation within the marketplace, and thus result in an atmosphere of higher cost to the system. So APG merely asks OCA's staff and board to recognize what benefit designs and delivery system models have worked over the past 30 years to produce affordability in California, and carefully consider whether its policies will incent further movement in that direction or undermine existing tested mechanisms that produce the result we all want, which is better quality healthcare at lower per capita cost. Thank you.
At the podium, please go ahead.
Thank you. Janice Rocco on behalf of the California Medical Association and our nearly 50,000 physician and medical student members. First, we want to thank the board and the staff for all of your hard work on these issues and the advisory committee for the work that it's doing. We would recommend that each of the board members listen to the recording of yesterday's board meeting because those who disagree with the methodology that's been presented here today made some important points, only some of which were shared with the board today. Healthcare affordability is obviously critical, and many families today do not feel that they can afford the healthcare system. The OCA statute asks that this board not consider affordability in a vacuum, but specifically names access, quality, and equity of care among its goals, the quadruple aim. At a recent meeting of this board, two of the board members talked about the access issues that currently exist today. First, there was mention of the Covered California narrow networks and how difficult it can be for folks in Covered California plans to access care, and then about the large group market and how the similar situation can exist there in terms of people having trouble getting timely appointments. A 3% target put in place for 5 years seems likely to result in wait times increasing and for those long wait times to apply to most of us. Last month, the Center for Medicare and Medicaid projected that the increase in the Medicare Economic Index, the cost to practice medicine, will be 4.6% in 2024. We need to consider, rather than ignore, the cost of providing healthcare when setting this target. If you do use median household income, the staff report mentions that for 2026, the projection is 3.6 as the percentage. And as has been pointed out, using 20 years versus 10 years and looking at the past produces a very different result. If the state's spending growth target is unrelated to the cost of providing healthcare, then it's going to be difficult to get buy-in from the healthcare entities subject to the cost targets to work toward achieving those targets. A 3% target growth is less than the level that any other state set as its initial growth targets. Other states work to lower their targets over time. We could start with 1% for 2025 and then lower it in 2026 and lower it in 2027 as one approach. The board's goal should be to set a target that's possible to achieve that doesn't come at the expense of equitable access to care. Thank you.
Thank you. Looking at virtual attendee Sarah Bibsa, we've unmuted you. Please unmute and go ahead.
Good afternoon, members. Apologies for the technical difficulties first time around, but my name is Sarah Bibsa, representing Young Invincibles, which is a national nonprofit advocacy organization that aims to expand economic security for young adults. And I'm here specifically to talk about the rising costs of healthcare, as well as the cost of living for young adults, a group routinely left out of conversations. The wages have not kept up with costs of living in healthcare. And speaking about this from a personal perspective, as someone who's expecting, the cost of prenatal care has been over the roof, averaging even $350 per ultrasound appointment, which is not sustainable cost for many families, including myself, in a dual income household. We strongly support OCA's proposed 3% spending target, and we really urge you to think about those who live in economic uncertainty at this time. Thank you.
Thank you. And here at the podium, please go ahead.
Beth Capel with Health Access California and Teamsters and Unite Here as well. One of the facts from the recent UC Berkeley analysis is that the average cost of family coverage is now about $10,000 for what the family pays in terms of premium and deductible. $10,000 in a state where the median income is somewhere between $80,000 and $85,000 a year. People do not have access to care when they cannot afford that care. And I know members of this board recognize that. I've had many conversations over the years with Dr. Pan where he's recognized the lack of affordability impairs access and leads to inappropriate emergency room use in some cases and inappropriate use of urgent care. The reality that consumers face is a vicious cycle of lack of affordability means lack of access to care, means they don't get their preventive care, they don't manage their chronic conditions, they end up higher acuity and seeking care inappropriately. We recognize that the law contemplates a cost growth target. This is a very different approach than rate regulation or utility rate regulation, where you simply add up the costs of care. The premise of OCA is that we are engaged in an endeavor where we will reduce costs while improving quality and access. That's why all of this is part of one law, the alternative payment models, the emphasis on quality and access, as well as the cost targets. But it starts with consumer affordability, and you've heard today and previously far too many examples of people not being able to afford care. So 3% is a good place to start. We wish it was stronger. We wish you could do negative numbers. Thank you.
Virtual attendee Travis West, we invite you to unmute.
Good afternoon, everyone. Travis West, Regulatory Policy Specialist with California Nurses Association. I just wanted to very quickly state that CNA agrees with the recommendation to the board of 3% for the first 5 years and agrees that no adjustments should be made for the time being. Thank you to the OCA board and staff for your hard work on this very important issue.
Thank you. Turning to our next virtual member, Tim Madden, we invite you to unmute. Tim Madden, if you could unmute on your end, please. Okay, unfortunately, we'll have to turn to the next virtual member, Kim Stone. We invite you to unmute. Please go ahead.
Thank you so much. Kim Stone of Stone Advocacy on behalf of the California Orthopedic Association. We are also concerned about basing the cost increase on consumer data instead of on the actual cost drivers to providing care, and urge consideration of the factors that go into costs as well as patients' and consumers' ability to pay. Thank you.
Thank you. Don Shinsky, we invite you to unmute. Please go ahead. Don Shinsky, if you could unmute on your end, please. Okay, turning to our next virtual member, Bianca B. Please go ahead and unmute. Thank you. Bianca, try that one more time. Please go ahead and unmute.
Sure. Thanks
There you
again. My name is Bianca Blomquist. I'm Policy Director for Small Business Majority. Really appreciate today's discussion. Want to congratulate the board on the progress that's made so far, and including the proactive outreach to our network of small business owners. As folks know, Small Business Majority is a national nonprofit advocating for small business owners access to high quality, affordable health care, both for themselves and their employees. They employ roughly half of California's private sector workforce. So again, we appreciate the board including these perspectives in your work to develop the cost targets. Small Business Majority strongly supports the 3% spending growth target, and we are asking the board to make no adjustments or implement any delays in slowing healthcare costs in California, frankly, because the healthcare costs too much for regular Californians. The costs keep growing. Small business owners and their employees frequently delay care, skip tests, fail to fill prescriptions because of the high costs. Moreover, high healthcare costs stifle entrepreneurship and small business growth, in addition to hurting their employees. Wages continue to get squeezed by healthcare costs, and we know that slowing the growth in healthcare costs means small business owners can spend more money on wages for their workers, better healthcare, and more robust benefits. Small business owners have shared these perspectives that underscore these points during the OCA board meeting in September, during long-form conversations with board members in November, and have taken time out of their busy days to record videos that outline how high healthcare costs are impacting their ability to run their business and provide quality jobs. Again, thanks to the board for its willingness to engage with our network and other small business owners across the state. We look forward to continuing to engage with the board as it finalizes these cost targets and to ensure that these healthcare costs for small business owners continue to be addressed through thorough and robust oversight over these cost targets. So thank you so much.
Thank you. Virtual member Bill F., we've unmuted you. Please unmute on your end and go ahead.
Good afternoon. Thank you for allowing comments. My name is Bill Failing with the Carpenter Fund Administrative Office located in Oakland, California. I'd just like to comment that we support the 3% over 5 years, and we believe that it is time to send the medical industrial complex a clear message that the status quo is not acceptable and challenge them to do better. Thank you.
Thank you. And that concludes public comment.
Okay. If I was graded on getting us to an endpoint, I'd failed. But I will say, I think the board members all agree that leaving sufficient time for public comment, hearing the balance was really, really important. This was the big item that needed to come first. So we will make adjustments in the rest of the agenda, although all important items, I'll take some liberty of shaving them down as we go through. There will be no additional break after about 20-25 minute lunch, and we'll get back here at about 1:20 or 1:25 and start. Sorry, board members. If you were looking forward to catching up on calls, we'll do that at the end of the day. See you back here soon. Thanks. I will note that we thinned out quite a bit. Note to self, one reason to end with the big one. Keep everybody know, or at least say you're going to slot it in when you see fit. Okay, all right. Was waiting for Elizabeth to come back, but told she'll get here as soon as she can, and hopefully before her sandwich, the mayo has turned, or sorry, the avocado has turned brown. Okay, Vishal, do you want to introduce our next? Oh, do we have to reestablish quorum? We do. So let's go back and take roll.
All right, Secretary Dr. Mark Galley.
Present.
Dr. David Carlisle. Dr. Sandra Hernandez.
Here.
Richard Cronick.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell. Okay, thank you. Noted for the record. Dr. Richard Pan.
Present.
Don Molds. Thank you.
Okay, reestablish quorum. Thank you all for the truncated lunch, and we're going to power through, but I've been told we're going to get through it. So, Vishal, do you want to, I think you're back up and inviting our guests up to present?
Yeah, thank you. And I'll hand it off to Margaretta to introduce our guest speakers.
Good afternoon, members of the board and members of the public. Today, I'm excited to share an initiative that OCA has been working on to complement the spending targets through identifying and sharing examples of cost-reducing strategies. So if we could go to the next slide. And the goal of this project is to highlight examples of successful cost-reducing strategies that also maintain or improve quality. And OCA is working with health plans, hospitals, physician organizations to highlight examples of these strategies that have demonstrated results in their organizations. And we intend these strategies to be a resource to support healthcare entities in meeting OCA's spending targets. So to start this project, we spoke with industry associations, quality improvement collaboratives, and others to understand their approach to cost-reducing strategies and seek introductions to healthcare entities that are implementing successful programs. So we interviewed several healthcare entities across California to identify strategies that reduce costs and are sustainable for the entity to implement and maintain. From these interviews, we are working with several organizations to develop a summary of their cost-reducing strategies to share on a new HCI webpage that will be released hopefully within the coming months. So, and I would like to note here that OCA did not independently verify information about these strategies or results provided by the healthcare entities, and we're not endorsing any specific healthcare entity or strategy. We really have identified these as helpful examples of cost-reducing strategies that can be a resource to others. So today we're excited to have two organizations, Anthem Blue Cross or Elevance and Sharp Race Daily, who will be sharing examples of a cost reducing strategy within their organization. And before I turn it over to the Anthem Blue Cross team, I wanted to announce on the next slide that OCA is seeking additional cost reducing strategy examples. So if you have a cost reducing strategy in your healthcare organization that you would like to share with OCA, you are welcome to send that information to our general inbox, and we'll follow up for more information. So in these examples, we're seeking programs that might address a specific population, implementation of best practices, or an effort to increase care coordination as some examples. So, and we are interested in these submissions to hear a description of the strategy, the purpose or rationale, and results that have demonstrated cost reductions and improved or maintained quality of care, and of course, any barriers or challenges to implementing such a strategy. So now I'd like to turn it over to Mohit Ghosh, State Affairs, and Dr. Tiffany Inglis, National Medical Director, Women's and Children's Health from Anthem Blue Cross, to share their cost-reducing strategy focused on improving maternity care. So Anthem will present, and then we'll have time for questions, and then we'll turn it over to the Sharp Race Daily team. So Mohit.
Thank you, Margaretta, and thank you to the board for having us present today. Important work here, very much in line with the mission, the vision, and the intent of what OCA is trying to achieve. For those of you who don't know us, Anthem's been in the market here for 80 plus years. We provide coverage in every program in the state. We were at the beginning of Medi-Cal managed care, helped build out the system in the 90s, and continue to do so as good stewards of the healthcare dollar for the state. Throughout that time, we've seen a ton of innovation in how we do our work, whether it's in Medi-Cal or whether it's in the commercial space. And what you're going to see here is a good example of something that was learned, something that was driven by evidence, and then something that was replicated across not just California, but across other states as well, from the crucible of learning here in our state. It has to do with maternity care. Very importantly, we recognize that maternity care, both for the mother and the child, are integral to providing comprehensive care in our system. It's part of our mission. And you'll also see the other pieces of our mission in this presentation, which is to meet consumers, meet our members where they are. How do we help them where they need help? How do we make sure they have the ability to access what they need to access at the time at which they need to do so? So I'd like to introduce Dr. Tiffany Inglis, who, as was mentioned, is our National Medical Director for Women and Children's Health. This entire process was created in her shop and has then propagated from there, but really good results, and I hope we can have a meaningful discussion as part of this presentation. So feel free to interrupt us, or we'll take questions at the end. Tiffany, I'll hand off to you.
Thanks, Mohit. Can you guys hear me okay?
Yes, we can.
Hopefully, yeah. Okay, sounds great. Thanks for having me, Tiffany Inglis. Just briefly, I am an OBGYN by training. I practiced for quite some time and came to Anthem in one of our plans, and then moved to our national team as the National Medical Director for Women's and Children's Health, getting to work with Mohit and so many others across the country in our various plans, and really looking at how we address maternal, child, and women's health. About 4 years ago, we really sort of took a step back and said, how can we make sure that we truly understand our population, understand what's going on in our population, and understand when we can impact at moments that matter, is what I call it, with programs that can be really helpful to drive those things for membership. And so as we did that work, we can go to the next slide, we sort of came out of that work with very clear guidance on how we can improve outcomes for members and how we can also, in doing that, drive spend reduction. And so I'm going to start with the second point because it really did start in California. We had doula pilots. We had 3 states, and California was one of them that significantly contributed to early work around doulas. And when we knew that work was happening, we took a deep dive and we actually did a peer-reviewed study. It was released in the Lancet, and our Public Policy Institute has done a review of that. And we actually just finished a refresh of that data, and we're about to publish that as well. But we wanted to understand, how do doulas help women? How do doulas help birthing people? When and where? And then how can we increase their use if that's the case? And so what we found was that they significantly improved outcomes, and we'll get into that in a slide later. But there's a significant improvement in moms' outcomes, babies' outcomes, postpartum outcomes. We know over 50% of women die in the postpartum space. And so how do we use our tools to enhance what we're already doing? Doulas, if you don't know, are non-clinical supports. They don't compete with the OBGYN. They don't compete with the midwife. What they really do is come in and support women through the process. And what we hear over and over and over again in maternal child care is, I didn't feel valued, I didn't feel heard, and I didn't feel understood. And when we work with doulas, we hear women repeatedly, especially women at risk of receiving disparities in their care, say, this person helped me find my voice, they helped me understand what was happening, and they helped me feel more connected to my care. And so that was really a big driver. So we've expanded our doula program significantly. And as Mohit indicated, the state used a lot of that to even drive that even further, which is amazing. And we've seen that elsewhere too, which is just really, really amazing. What some of the folks who helped us.
Sorry, Tiffany, just as an
Yes.
addition to that, when the doula benefit was launched in California prior to that on Jan 1 of last year, we were in meetings pretty consistently with DHCS, and JC actually pointed out to us that she's like, well, it's because of you that we actually started looking at the data. So it's good that we've been able to have that kind of an effect. So Tiffany, sorry, back to you.
Yeah, no, and I think I'll lead back into one with this. A big piece of the work that we also found when we were doing this doula work is there are barriers to getting doulas to people. Do people understand? Will the patient understand what a doula is? Does the patient understand how to get to a doula? But doulas don't work with insurers very often, right? And this is a new space for them and a new space for us. So how do we do that better? And then how do we break down the barriers between delivery providers, OBGYNs and midwives and doulas, and make sure that they can be present and they can be there to support the patient, and that we're all understanding that there is not a competition here. This is to support one another and to help the patient to get a better outcome. And we have what's called OB practice consultants. They're clinical liaisons. So they're all clinicians, nurses, worked in the field, labor and delivery, postpartum office space. And their entire role for us is to focus on that provider relationship. So they are aligned into their state, to the providers in their state. They live in their state. And they also helped to support the conversation around doulas with our providers and with the doula organizations to help break down some of those barriers. Because again, we can just say there's a coverage, but if you don't increase access, you don't provide dollars for access and funding for access, which we did, and you don't help support that conversation about the role that everyone has and the why behind why we think it's so important, it's harder to get things moving. So this is all like deep, hard work, right? And but it really is impactful. And I think that's the beauty of it, is that you see this positive at the end. But the practice consultants also have a significant impact in other areas. That's one of the places that they impact. But they really are our provider-centric role. And we're going to talk a little bit about what they do specifically, I think, in the next slide. But they also are the one who drove some of our postpartum maternal morbidity mortality initiative. And what is that? So what that is we created with the support, and we shared this with ACOG, of some of the tools that they have. We created sort of a one-pager for providers focused on the behavioral health and cardiovascular causes of death. Cardiovascular is the #1 killer of women postpartum. Behavioral health is the #1 killer of all other groups postpartum. And so what we did was we created a screening tool that providers can use with members to help them to know when to recognize symptoms that might be troublesome and not wait too long, and get them to care sooner and faster, and really reduce those really potentially preventable horrible outcomes that we don't want. So what we've really seen is the providers have been really happy about it. A lot of them have laminated it. They take it with them. They can speak to it. And it gives them an opportunity to have an early conversation with members about things to look for and where to seek care if they start to see problems in that postpartum space. The other things we've done is practice consultants work closely with our value-based care and our non-value-based care providers. But what we see in that space is when our practice consultants work with our value-based care providers, there's a huge impact to maternity outcomes. And we're going to show you that in just a second. And then I think digital tools driven by predictive analytics, driven by knowledge and understanding of what drives to poor outcomes. We now understand what our top drivers of C-section is, what our top drivers of preterm birth is, why certain women with hypertension progress to a further state of their disease, and what those risk factors might be, and then identifying those risk factors early and getting them to higher touch care, and then using digital tools to not only make that easier for them, but then also, I think a lot of times we don't talk about this, but healthcare has always been a very I'm going to give you a list of things, you're going to turn around and do it, and you have to do it that way. And I think when we think about the way we learn, if we're all very honest, I have an alternative learner in my home. He doesn't learn like that. And a lot of people don't learn like that. So being able to have video content or written content or repeated content or checklists and questionnaires, it really gets to the idea that everyone learns differently and maybe needs to have the information presented differently and in different avenues so that they can get what they need from it. So we can go to the next slide. This slide digs into the data behind the doulas. This is our data from our Anthem work. This is the first study. The second study, I've seen the preliminary results and I'm waiting on the final readout. It really supports these same findings. And it was a wonderful thing because it's about 3 times more members getting the care. And so it was great to see that confirmation. And we will release that and share that as we get it. But I think the biggest thing about doulas is, yes, it reduces preterm birth rates. It reduces cesarean section rates. It reduces low birth weight babies. It reduces hospital admissions during pregnancy. It reduces ER visits in the postpartum space. It reduces NICU usage and NICU admissions, which not only is something we want to avoid for babies, but for families, right? Families who have NICU stays have increased incidence of PTSD and anxiety and depression. And what's not on here and separate from all of that is we saw about a 60% reduction in postpartum depression and anxiety overall in members who were supported by doulas. So, these are huge impacts in spaces where we know we're not doing a very good job in the maternity world, right, for all moms, and we're really not doing a very good job for Black moms and other moms in at-risk populations. So when we looked at these studies, we see huge impacts in that space, and then doulas overall nationally and in some of our work show we're closing those care gaps and those disparity gaps, which is huge, getting members to care earlier, getting more consistent postpartum care, which is all we know very important in driving to these outcomes. We can go to the next slide. These are some of the places where we've shared this work, and these are all external shares. And these are all live links. So if there's any more detail or information you want regarding, what we've done in the doula space, what that study showed specifically, any of our provider enablement work, it's all here. So we wanted to give that to you all. We can go to the next slide. And then this is really about our practice consultants. So OB practice consultants, again, are clinicians with maternal child expertise. They're invested in their health plan. They live in their state. They have a clear understanding of what our programming is and what our offerings are, and they are the one-stop shop for providers. If I have a problem, my OBPC might not be able to fix every problem, but they know how to get you to the person who can. And so they really are that source for the provider. At the bottom, you'll see some comments our providers give us all the time. They love this program. and they're really happy with it. They bring real-time data back to the providers. They help them close care gaps. They help with understanding maybe when they're having a frustrating time not getting something they need. But then they also help because the providers then say, you know, Tiffany needs more support. I don't have this. Do you have this? Can you get her lined up to get that care? And so then they take that back to the health plan and they get that member into case management or into a provider that they need for a specialty care need, or we share that doula access back and forth and get members into those spaces. And then when you go to the next slide, this really shows the impact of that program. So when you talk about this program and the link on the far side is also a live link. Becker's did an article about this program specifically, but I'll break it down a little bit. The top line is our value-based care program in Medicaid and the impact that it's had in the states where it's present. And the middle line is the practice consultants. So when the practice consultants are working with providers that are not in a value-based care program, we see a 2% reduction in total birth cost savings. We see a 2% reduction in maternal first year savings, and we see a 4% reduction in babies first year savings. That stems from a decrease in low birth weight, getting them to care earlier, and making sure their adequacy of their care is better. When we combine our practice consultants working with value-based care providers, that's what we call sort of the secret sauce. We see a 5% reduction in total birth savings. We see a 5% reduction in maternal first year savings post-delivery, and we see a 10% reduction in baby first year savings. That again stems from this reduction in preterm birth, reduction in low birth weight, improving adequacy of care and timeliness of care. And through that program, what we've also begun to add is health equity measures within our value-based care solutions. And then also in parallel to that, as we went live with those measures, we also partnered with March of Dimes to fund. We had a training on implicit bias for our staff in 21, but we just recently did a complete revamp of the training and a repeat of the training in 23. And then we've offered that training to our highest volume providers, up to, I think it was almost 500 providers were offered free training on implicit bias. So really trying to focus on not only improving care for all, improving these outcomes, but also like decreasing these disparity gaps and making sure that we're addressing those populations at most need. I think that's my last slide. I said a lot. I talked fast. I know I did. So I'm happy to take any questions. Yeah.
Yeah, and I'll just make a couple of points real quick. One is that, you know, these things take investment and they take time. I think that's very important to keep in mind as we talk about cost targets and things that we do within the marketplace. The other is that it also matters tremendously to think through how the provider community can lock into this. So there could be some providers that are ready, willing, and able to do these types of joint processes. And there are certain providers who just might not have the capacity due to either workload or lack of office staff, lack of relevant NPs within their practices to be able to make these connections and make the work together meaningful. So those are two areas that we wanted to make sure that folks understood that when we look at this, this is very much part of our plan at Anthem of doing equity by design, right? So even I've taken the implicit bias training. I have no customer facing work that I do directly in the care delivery system, but we've made sure that our entire teams are taking the implicit bias training so that we recognize how to deal with issues when they arise, whether you're a leader in the company or whether you're a frontline case manager. So that's one area. The other is to really also emphasize that as we move forward through this process, these alternative payment methodologies are important. Value-based purchasing is important, but we also have to look at the underlying run rate and the cost of care, right? And whether that's pharmaceuticals, which we are not considering in a lot of this conversation across the state. In fact, the Sovaldi example that was cited as a one-time change in a different state, right? I mean, I don't know if the Sovaldi example would necessarily apply in the way THCE is being calculated here in California fully, right? Because we're not counting the cost of the drug, we're not counting all of those things because that's not in the statute. So as we think about costs, as we think about alternative payment methodologies, and as we think about really enhancing the value of every dollar, whether it's a commercial plan or whether it's DHCS, or whether it's CMS for Medicare, or in some cases for the dual eligibles in the state of California. I'm just hopeful that the data that we are consistently sharing with Vishal's team, where at every table I sit on the value and investment and payment work group for Margareta. I get there's too many work groups and too many names, but we're proud to be a part of the process. We really feel like we can make a difference through these types of things. Scalability matters, and we're trying to do that. There's a lot of barriers in the work that we're doing, including the lack of availability of doulas statewide. So we're focusing now on training, et cetera, to help close that gap as well. So happy to take any questions.
Okay, I would really turning to our team. Do we want to do both presentations and then take questions at the end, or do you want to pause here?
Separately.
Separately? Okay. Questions? Richard Pan.
Thank you for your presentation. I was proud to work with Senator Nancy Skinner and getting the doula benefit up in our Medi-Cal program.
We proudly supported Moms 2020.
Yeah. So let me ask you a question. So this was the doula presentation was based on the Medicaid population, right? That you took care of, right? So
it was the pilot was the Medicaid pilot that we shared with DMC. Yes.
So given these results, is Anthem thinking about scaling it up to the commercial side and financing it yourself, because you're going to get savings based on this?
Well, these are active discussions. I think the scalability factor, and I'll defer to Tiffany, I'm sure you're having those chats, but without getting into too much, anything you can say about that?
Yeah, so we are actively looking at how we roll this out to commercial. We actually have some employer groups that already cover a benefit, and in 2024 we'll start supporting them with a doula network. So I can tell you that. So very much so, yes.
All right. Well, part of the reason I asked the question is that, in fact, when I was chair of the Assembly Health Committee, I had all these pilots we talked about, and yet none of them were taken to scale. And one of the questions was like, well, if these were so great, why don't you take them to scale? And so I think, one of the things that's going to be important for us as we're trying to figure out how to, reduce costs is that to have an understanding about how, health plans, provider networks, everything else, right, deploy resources in a way that if they see something that actually you're incentivized to roll it out further. And then I guess the other comment is appreciate the OB consultant part. My guess is, I'm guessing, because obviously I don't have data yet, is that that model would probably work with lots of different specialties and lots of types of care. I mean, I know the frustration as a physician who still practices about basically, in some senses, it seems like the medical director's job, not to pick any particular person, is to say no, instead of actually having someone in the health plan who's actually trying to help, right? And in fact, there's probably a lot of opportunities there as well. So I'm hoping that you're also thinking about how do we take this to scale, not only within OB, but hey, is this a model that can be applied in other ways to other healthcare delivery works, and do you get the similar kind of results, right? And thinking about that as well.
Yeah, so happy to. These are great questions, right? And that's great comments. So I always say the same thing. I'm like, great, we did something for 50 people. How are we going to do it for more, right? Can we reproduce it? So let's start with the PCs. The PCs, we started with a team of 8 solely supporting a few Medicaid markets, and now it's a team of 35 supporting all of our Medicaid markets and almost all of our commercial markets. So like that has been scaled within maternity. And then, yes, to your point, obviously recognize the value of this. And from a primary care side, there is a team that supports primary care docs. They're not clinicians, but in the specialty side, we actually have taken this exact model and scaled it to oncology. Now we actually have oncology practice supports, and we've seen similar success, and we are just beginning down the same path for cardiology. So 100%, that's exactly our strategic vision was, and that's really been the work we've been doing is what works, where, when, and how, and then how do we do more of it? And from doulas, same thing, the expanded study was able to get 3 times as many members from an expansion of not only the pilots within like California and the markets that we looked at originally, but we now have many more states supporting doulas. And we also have a lot of conversations in our states now being leaders in the thought leadership of discussion around how do you cover it, right? Because really the long-term vision is how do we get members easier access? And that's really the key. So 100% with you. And that's exactly what I do every day, is take what we do that works and try to make it grow.
And then a quick question here. So when you say these first year savings and the OB practice consultants, that's the net savings, right? That includes the cost of actually having the program.
Yeah. So, and
built into
those
that?
savings, yeah, so those savings you saw exactly 100%. Yes. And those program evaluations, that's our third one in a row over 5 years of performance
Okay.
throughout and while we scaled. And that is consistent every single year. We continue to have this kind of impact.
Okay.
So,
All
yeah.
right. So that,
Yep.
so that's a net. Okay. Not a, like, then include the cost. Okay. And I just want to, again, thank you for emphasizing the fact that you don't lead to these kind of results until you actually put money in to invest in the change. If the change doesn't happen, you don't get the results. Thank you.
Exactly. Yeah.
Great, thanks. Elizabeth?
Thank you, and thank you for the presentation. I represent jumbo employers and public purchasers, and this is literally at the very top of their priority list, as I'm sure you know. They pay for the other half of the births in the country, and we have very active, engaged, sophisticated purchasers who are really looking for this type of innovation. As you know, like Walmart and CalPERS have already added the doula benefit. We've gotten enormous consensus from our members. They want this. So I think scaling will be very attractive, and to the extent that we can help drive this change, I think there's a lot of demand and interest. We're also looking for the mental health integration, for bundled payments, just to, I mean, I think you will be pleasantly surprised by the readiness from our large purchaser members to help with this. So would love to talk further about.
Yeah, we're absolutely, and you know, that's music to Tiffany's ears, because that means her team can actually do more, which is what we want to be doing in this space.
Great.
It really does help drive access, drive equity, address disparities in a way that normally you wouldn't. An example that was given yesterday during the advisory committee kind of stuck out to me, because we've been in the 1-year implementation on the Medi-Cal benefit. And the gentleman from one of the clinics in the rural north pointed out that they deliver 700 babies a year in that particular county, and yet there's only 2 doulas available.
Oh yeah.
So there, you know, so again, even if we scaled it, we still have to have the workforce come together in a way that supports the scalability of the project, and that again requires investment.
And that is sort of thing we're eager to partner on. But I also just, again, this is one example of one innovation in one clinical condition that can generate savings. And I think it's really important that you're showing us the savings that are achievable through better care. Better care
but I also want to be careful to my earlier comment, which is that not everybody's ready to do what we're ready to do. Right. Absolutely. And so, again, there could be a level of investment even in the provider community that has to occur to work with us to make this happen.
Well, we're really pleased that there are so many resources already out there that can be deployed for this. And we really are, it's just so encouraging to see the evidence that we can reduce total costs by doing better care. And I think this is just one example of many. So thank you.
Absolutely.
Rick? Thanks you for the really interesting presentation. I'm assuming that in almost all your Medicaid business is capitated or HMO business.
In California, it is. There are some states where it's not.
Yeah. And I can imagine, sort of, I used to work in a Medicaid program, so I can kind of imagine the legal issues. But why do you need, I mean, the approval of the Medicaid program to do this? If you think it's going to save money, why not just do it?
I'm going to really, I'm just in the interest of preserving my employment, I'm going to completely not answer that question. But I will say, no, these are all labors of love. There's teams that work on these issues consistently across our Medicaid team and our commercial team, and we are always in front of the agencies on a consistent basis, trying to work with people to move things forward. But yes, there are, I mean, the rules are the rules. We have to follow the rules, and that's what we have to do.
I'll defer to the lawyers in the room, but I'm going to avoid taking the bait too. I think that's what that was.
Thank you, Secretary Galley.
Yes.
I was hoping you'd bail me out on that one, like we're in charge.
I'm not going to go there.
Yeah.
Yeah. I'm going to ask not a pivot question, but Tiffany, I'm wondering, can you speak to how doulas modulate demand for sort of traditional providers in the sort of perinatal continuum? And specifically, do they change the need for sort of the volume of not just more costly, but scarcer providers as well? And did you have any experience with that?
Yeah, so I think a yes and a no, right? So you still need the delivery provider, you still need the midwife, you still need the OBGYN. But I think what we've seen and what we talk to providers about, and especially providers who've really joined us in the effort and really taken this on, it's hard to ask a provider to understand everything about a person's social needs in the 15 minutes they have to see them, right? Or the 5 minutes sometimes. And so I think the real opportunity is that this can take some things off of the plate of the provider, of the delivery provider, I should say, so that the midwife, who's better attuned to the social supports, better attuned to what's happening, has usually often a better rapport with the member to be able to ask the questions about what they may or may not need, and then to really take that piece and let the doula be the support, be the voice, and be the partner to the member so that they can then talk to the provider and get the answers that they want. And so I think when we see it and it works well, and to Mohit's point, when everyone's invested, that's the beauty of it. And I will say there was a behavioral health comment, and I didn't get into it, and I should have, and I think it loops the two questions together. You can't address the poor outcomes we see in the maternal and children's health space without saying behavioral health, physical health, and social health are one thing, and we need to start talking about them in that way. And so bringing in these supports to be able to address all of the pieces easily and consistently for the member is the only way we're really ever going to get there. I truly believe that. And so, and how we save money is by driving quality, right? Like that's exactly what we do. So I think from that perspective, it doesn't necessarily alleviate the need for them, but it helps to make sure that the member can use the time they have with that OBGYN or that midwife more effectively and feel supported and valued and part of the care, which then drives to that better relationship. And it lessens the load for the OBGYN and the midwife from all the things, the external other things. They know they have somebody who can handle that and help them.
Yeah, well said. We have, I mean, there's on the primary care side, there's good evidence of the similar model with community health workers. And I think those of us who've done it long enough used community health workers in that sort of same way, not to change the need for a physician, nurse, NP, PA, whatever, but to really, as you said, take some of the load away and frankly have those folks with that clinical expertise do that piece as well as they can and augment it with the support of community health workers. So in many ways, the Medicaid scaling or pushing forward a community health worker benefit along with the doula benefit, along with some similar aspects in the behavioral health space, titled a different name, but similar function, I think is going to be really key for California. And I appreciate the question about scaling into commercial markets, really important, but it'd be a big deal for California just to scale these within Medicaid across the state, because 1 in 3 Californians get their care in Medicaid. So, all right, now I'm going to take secretary hat off and be back as a common board member. All right. Should we move to our next presentation? Yes. Thank you,
I will just briefly,
Anthem team.
Oh, yeah. Yes. Thank you very much to the Anthem team. Thank you, Dr. Inglis. Really appreciate your presentation. And Yes, if we could, thank you. Move to the next slide. So I'm happy to introduce the Sharp Race Daily team to share their cost reducing strategy that's focused on population health management. So this is just one example from their work. We have Stacy Hurantes, Chief Executive Officer, Andrea Snyder, Vice President of Health Services, and Dr. Andy Dang, Chief Medical Officer. So again, Sharp will present and we'll have time for questions. Stacy.
Thank you, Margarita. Thank you. We're so pleased to be here today. Next slide, please. We really are happy to share our journey at Sharp Race Daily. Next slide. And the next slide, please. There we go. So 101 years ago, two physicians, a general practitioner and a specialist, really believed that coordinated care was the best for San Diegans. And so they created the first multi-specialty medical group in San Diego. And we've been building on that care model ever since, working through their legacy. Next slide, please. So in 1985, Reese Daly joined Sharp Healthcare as a medical foundation model. And in the Sharp Healthcare system today, there's 3 affiliated medical groups, 4 acute care hospitals and 3 specialty hospitals, and a not-for-profit health plan, Sharp Health Plan. Next slide. So a couple things about Sharp Race Daily. You can see our number of physicians and advanced practitioners, 19 clinics across San Diego County, and 2,800 members supporting those physicians. The one point I really want to make on here is the 70% capitated. So we've been taking capitation since 1985 was our first capitated contract through Pacific Care and Secure Horizons, if you remember those names years ago. And pretty much all of our HMO contracts are capitated, and our hospital partners take capitation for all of our health plans except for one. And what that enables us to do is really hone in on the HMO model, because under HMO benefits, the benefits are more comprehensive than the PPO benefit structure. And we believe in that because that's part of our coordinated care model, having a primary care physician, having benefits that support care that we want them to get, including pharmaceuticals. Next slide. You can see this is just the number of lab tests we do. This is pre-COVID, 1.4 million physician visits, and you can see radiology and the other services that we offer. Next slide. And my last slide before I hand it off to our experts here, Andrea and Dr. Dang, is we started the Sharp experience over 20 years ago. And our vision was to be the best place to work, the best place to practice medicine, and the best place to receive care in the universe, seriously. And so it's really been a cultural change over the last 21 years, but it's also a process improvement change where we've eliminated waste out of our system. But we've done it with a heart. We want to make sure there's compassion and care that we provide every day to all of our patients that come into whatever part of the Sharp system. So with that, I'm going to hand it off to Andrea.
Thanks, Stacy. Next slide, please. So in addition to the Sharp experience, woven into our culture and DNA is this SRS value proposition, where we truly believe that the way we provide value to our customers and payer partners is through high quality and service and maintaining, lower total cost of care. And the way we can demonstrate that quality and service are through IHA awards that we've received multiple years of top 10% for clinical quality and patient experience. And we also are 5 stars in their Medicare Advantage ratings, which we're really proud of. And the way we accomplish that is, as Stacy said, with that investment from the capitated dollar, we can really wrap services around the entire patient. We have population health, we have utilization management, which is a team that deals with a lot of that administrative burden that was brought up earlier today. Support teams like our virtual on demand, where patients can call in and get kind of like a televideo visit for urgent care services and treat UTIs and other things that can be managed easily. We also have a bidirectional patient portal. 68% of our patients are actively engaged in that, so they can send messages to their physicians, get refills, get advice, and all of that is provided outside of traditional what you would count as visits and encounters. And so having that capitated dollar allows us to invest in that infrastructure. Go ahead and go to the next slide. And so we are NCQA accredited for our population health program. We really see that as like a gold seal of approval. It gives us a framework for ensuring that we are providing the entire suite of population health services that we hold ourselves accountable to. One of the first place that starts with is a population assessment that we do annually to understand what the needs of our population are and make sure that our programs are aligned with those needs. I bolded and underlined data integration here in the suite of services that wrap around the patient, because I really think it's critical to have a robust data team like we do that can mine the data. And we actually in the last 2 years developed a predictive modeling system mechanism that identifies with 100 different variables patients that are at the highest risk for having a hospital admission within the next 30 days. And so on a weekly basis, our case managers have that high risk list to outreach to those patients and engage them in case management. And since we revisited that process, our baseline engagement rate was about 13% of patients agreeing to participate in case management. We're now up over consistently 60% in that outreach activity. And that's in addition to referrals that we get from our primary care physicians and specialty physicians. But it's also important for us to anticipate who those high-risk patients are and engage them. And so the case management team and the rest of the population health team collaborate with our care delivery systems, our health plans and payer partners, as well as community resources to make sure that those patients' needs are met. And go ahead and go to the next slide. And so that stratification results in us thinking of our patient population in these terms. On the base, you see the walking well. So patients that we outreach to for preventive care, and that's for all of our patients, HMO and PPO, where we remind them about, getting their cancer screening tests done. We also have a robust Center for Health Management that has extensive health education programs like our diabetes prevention program. So we outreach to patients that are at risk of progressing to diabetes. We engage them in a year-long program that is CMS certified diabetes prevention program. And the great news is that 88% of participants in that DPP program achieve one of the measurable outcomes that CMS expects. So that's a significant reduction in hemoglobin A1C, which is a marker of their blood sugar control, and or weight loss. And they, on average, they lose about 6% of their body weight in that year-long program. And they're taught things like stress reduction, sleeping right, eating right, all of those things that make life better all around. And then as patients progress up the pyramid, we adjust the resources that we wrap around them based on their risk. So we've got programs for chronic disease, case management teams that focus specifically on diabetes or congestive heart failure. But we also know, progressing up that pyramid, that there are patients with multiple chronic conditions. They don't always come in nice, neat packages where it's just diabetes that we're working to address. They have multiple conditions, and so we increase the resources that are provided to those patients. And then at the very tippy top, you see the most complex patients that are frail, elderly, or for other reasons can't get in to see their primary care physician in person. And so we actually have a care at home program where we send nurse practitioners into the home to provide the primary care and liaison with the patient's assigned PCP. We also wrap other resources around them like social workers and case managers. And across the pyramid, we leverage technology. It's really important for that human touch, like you heard about the doulas in that prior presentation, but it's also important for us to reach more patients and a broader population to leverage technology. And I'll explain a little bit more about that. Go ahead and go to the next slide. So these are examples of members of the population health team. Many of them I've already mentioned. Our certified nurse case managers, which are really at the heart of it, but that is an expensive resource. And so it's important for us to leverage others like medical assistants, health coaches that can set goals and work with patients on achieving those goals, whatever they may be. It may be quitting smoking or reducing their blood sugars. Care specialists, community health workers, our data analyst team, I mentioned how important they are. They also tee up reports for providers and other clinicians that are in touch with patients that can address whatever care gap those patients might have. And diabetic educators are also critical, especially with that diabetic population. Then go ahead and go to the next slide, and I'm going to touch on our project managers. It's important on our population health team. We've got project managers that help deploy the technology that you see here. So we use remote patient monitoring like scales and blood pressure cuffs and blood sugar monitors in the home with patients to keep track of how they're doing. And we deploy these resources and keep track of how the patients are doing. Go ahead and go back. There you go. Thanks. So that we can keep tabs on them, and if they have deterioration or they're struggling to manage their sugars, we can intervene sooner, prevent those ED visits, prevent hospitalizations, keep them at home, healthy, home, work, and play. And then we also have texting programs, which I'm going to touch on in the next slide. You see an example of this here. It's an interactive diabetes texting program where the question is, what effect does unsweetened fruit juice have on blood sugar? And it gives them options, and you can see that the patient responded and they get reinforcement of healthy behaviors. And we have them across a whole bunch of topics that gives us the ability to sprinkle in education, a couple of times a week, as well as keep tabs on patients so that if there is a problem, we can intervene sooner. Go ahead and go to the next slide. And this one lists examples of those texting programs. We actually have 19 in total. Things as like healthy living, which is very broad, lifestyle management types programs. We've got condition-specific programs. We have a texting program that's specifically for patients post-hospital discharge. Again, we want to prevent those readmissions and keep patients home and healthy. We've also added recently in the last couple of years a postpartum depression screening, which is the right thing to do for our patients. This helps us keep track of moms who are maybe struggling. We get about 80 referrals a month from that program alone into our social work team, which we've expanded over the past 5 or so years from 1 to 4 social workers, because we recognize in the wake of COVID, the significant mental health needs of our population. And then we also have specifically developed a behavioral health texting program that helps patients with things like anxiety and depression while they're waiting to get into, for many of them, getting into, see a psychiatrist, because as you're all aware, I'm sure there's delays in that. So go ahead and go to the next slide. Just a couple of stories. I think they're really inspiring. This is an example of messaging we got from a participant in our diabetes prevention program. So excited about the progress that she'd made in that program. She also signed up for a follow-up program to that. This is our free health education programming, our Be Well for Life program. Because of her participation in the DPP, she reduced her A1C from 6.4 to 5.9 and lost 23 pounds. She's involved in exercise 5 to 8 times a week. Her husband says we've created a monster, and she's just excited to share these results. Go ahead and go to the next slide. Another example of successful patient stories. So this is a patient who was working, also a pre-diabetic patient, working on improving her healthy eating habits, working with a health coach. So proud of the advances she'd made in eating the rainbow and preparing meals for herself that included lots of fruits and vegetables, that she was sharing pictures of those meals with her health coach. Go ahead and go to the next slide. And the next one is a success story from a young, healthy, in his 40s, a husband, father of 2, who we outreach to complete his colorectal cancer screening with a FIT kit, which is a stool test that you can do at home in the comfort of home, and it's a low-cost alternative to colonoscopy screening. His actually came back positive, which he obviously wasn't expecting. Went on to have a colonoscopy, found polyps, and had those effectively treated. This is, he's in his 40s, and so it's possible that this could have progressed into a much more significant and expensive condition. The other thing that happened in this story is that his father, who had been putting off getting a colonoscopy for a number of years, was inspired by the story, went and got had a tumor that was effectively treated, and he's now in remission. So success story not just for this family, but also his father. Go ahead and go to the next slide. And I am going to hand it over to Dr. Dang to share the results that we see with these programs.
All right, thank you. I'm just gonna go back real quick to our text messaging, and I'm on the Healthy Living, which I get every Friday and every Monday around 10 o'clock in the morning. So last Friday, I got my tip. It says, make your weekly exercise date because it's easier to talk yourself out of a workout, but you're more likely to keep a commitment with a friend. So Stacy, you wanna walk with me later today? Because I'm not gonna do it. So we stood up all these programs, make all these investments in people, technology. What are the results of that? So as you can see here in our senior patient population, over the years, we're able to reduce our admissions per 1,000 patients over the years and sustain that. So that takes a lot of investment though, right? That's our nurse case managers making outreach for disease-specific conditions such as heart failure, COPD, but we also have nurse case managers in the clinic. So if a patient gets discharged from the clinic, we make sure they see their primary care physician or specialist as appropriate within 7 days. That case manager is also there to participate in that post-discharge visit and continue that education process and making sure that they continue that that plan for them to succeed. And then we also touch them within 2 days to make sure they picked up the medications, because how many patients leave the hospital and may not run to the local pharmacy and grab the medications that they need. Next slide. So just some more results. We invest a lot in our patients with diabetes because we really want them to have good outcomes. So we have 4 different diagnoses here: retinopathy, which is an eye condition which can lead to blindness in our patients with diabetes, myocardial infarctions, heart attacks, and then strokes. So the orange and sort of light green, lime green is 2009, 2010. This is before we started our disease management programs, and you can see our rates of heart attacks and strokes once we had our nurse case managers have been steadily decreased, and we've been able to sustain that. The last few years, we've had a little bit of a COVID effect. Don't know how to interpret all this. It'd be interesting to find out over the next few years as this trends out. In that second to the last or second to the left grouping of retinopathy there, you see that uptick. That's because we've actually improved our screenings. In about 2021, we bought in cameras that you can take when you go to your primary care office. They just take a picture of the back of your eye. That image gets uploaded to the cloud, and our optometrist goes up every day, pulls them down, and reads them. And if it's negative, great, the results goes back into the primary care doctor. But if there's something they're concerned about or there's early disease, they then tell their patient service rep to outreach to the patient and make an appointment. When we get them in, if it's really severe, we get them in even sooner. So there's a lot of work that goes along this, but we want to support our patients and really make it easy. Because if we make it easier for our patients, guess what? They actually get the care that they need. So that's all about what my idea of one-stop shopping, right? You go to your primary care, you can get your eye screen, you can get all this other stuff done to help support our patients and for them to be successful. Next slide. So in my training, I'm a general internal medicine doc, and I spent most of my career as a hospitalist. And I will say that one of the things that I saw as a break in the system was when I was co-managing patients with our surgeons, especially our orthopedic surgeons. When patients had an elective surgery, I'm managing their diabetes, their high blood pressure, and then when it's time for discharge, the discharge plan breaks down. They're there for another day or two unnecessarily in the hospital while we figure out that discharge plan. So what we did was created a program to do all this upfront even before they hit the hospital, right? So if I've seen my surgeon today and they say, Andy, you got your we're gonna replace your hip in a month, a referral goes out to a social worker in our team. They outreach to me and they say, hey, listen, Andy, you're gonna have this done. Your OR date is March 1st. What's your plan for home? Because the doctor thinks you can go home. They make sure they talk to my caregiver, because many times the patient thinks, oh, I can do this. I'll say something. That caregiver, that home care plan isn't intact. We make sure that's intact. We make sure that the patient gets their DME, their walker, whatever their needs are before they even reach the hospital. It's already at home waiting for them. And then we know physical therapy afterwards is important to support our patients for them to be successful. We already set up a physical therapy appointment with them. So we know your surgery is on March 1st. You go home the next day. The following day, you already have an appointment, date, time, address to your physical therapist. Because of this, we've been able to reduce our inpatient stays in the hospital. You can see from about 2 to 1.2 because our surgeons feel more comfortable because the plan's already in place. We don't see those delays. We have reduced emergency room visits post-operatively within 30 days, and we've also reduced readmissions because we're providing all the support for our patients. Next slide. So this is the quintuple aim, and this is something that we really believe in, and we make our decisions intentionally to improve our total cost of care by improving the total outcomes, the best outcomes for our patients. We focus on how we can improve well-being for our clinicians, and that's our physicians, our nursing staff, our MAs, everyone who touches the patient, and we're working on health equity. Next slide. So something we started doing several years ago is really leveraging or diving into social determinants of health. We know that people who have food insecurity, guess what? They can't afford the medications, right? So we want to support that, screen them, and then refer them to community resources as appropriate so they can help afford the medications also. We also know that patients who live alone have higher risk for ending up in the emergency room, urgent care, being hospitalized. So we're making these outreaches to try to support them, connecting them to resources out there. It's a journey that we're on. That number, we screen about 10%. That's about 20,000 patients we screen. That's about the number, and we continue to focus on this. Happy to say that we're moving to a new electronic health record in about 5 weeks, which will give us additional capacity to help screen more people. But we screen people not only in the clinics, but even on the text messages. I get food insecurity screening every year. I have to answer my 2 questions every year on the text messaging platform. So we want to do everything we can to help support our patients to help them be successful at home. Thank you very much. Questions?
Okay, thank you. Questions? Ian first, then Elizabeth.
Just to echo something that was said in yesterday's advisory committee and some of the comments earlier, I like these 2 examples, and this one particularly similar to an experience I had. It's the sort of thing that I really hope will become much more widespread as a result of the work this board is doing and the target setting in particular. Some years ago, the California Healthcare Foundation helped my union, the hospitality workers, map out the opportunity of wrapping around these sorts of programs, a work site-based community health worker type system to push people into these sort of programs and to help them follow, do the follow through in these programs. And there's huge opportunity. I mean, there's nobody up in your business and less concerned about HIPAA than your coworkers. But the challenge, even though we knew intuitively there's huge savings opportunity, the challenge was in a capitated environment. Trustees legitimately had very deep skepticism that we would realize the return on investment, that the real investment and time that would take to make it work. And my hope is that the combination of the pressures of the targets and the promotion of APMs and so forth that OCA is doing is that we're going to see a lot more of this. But like Elizabeth said, there's huge interest on the purchaser side of the table to work on these challenges.
Just Ian, to that comment, we're working with VIVA in San Diego. We're one of the pilot sites where VIVA, as a trust, can actually capitate providers directly with the Department of Managed Healthcare. So we're in that with VIVA in San Diego. So it's very exciting. We're looking forward to how it's going to play out.
Just very quickly, echo everything Ian said. This is sort of the care that we're hoping will happen, and the fact that you saw those reductions in ED visits and hospitalizations is like such a win. It's better care. Have you calculated the total cost savings that you're seeing so far? And if I missed that, I apologize.
Yeah, no, I mean, I think you can kind of extrapolate from the reductions, the senior HMO admissions reductions over multiple years. I think a key point, though, is that it took a couple of years from the time we started investing in this infrastructure to see those results. And it also takes time for that to play out. So I see that as a potential barrier. In terms of our CHF population with senior HMO, I can tell you that we estimate we save about $7 million a year in hospital admission costs in comparison to where we were when the program started. But I don't know if you want to say more about cost savings.
No, go ahead.
I think, we've seen, as you've seen, the savings, but there's a point where you're just going to maintain at that point. So you're not going to get further savings until you design new models to get them out of the hospital altogether, right? And do that safely. So we're at that point, recovering from COVID, getting on a new EHR, and then looking at how we can design and pull things more into the ambulatory setting.
That's great. And again, just very encouraging about what is achievable. Even on a small scale, you're seeing this type of impact. And as the purchasers support this direction, and I think there's huge opportunity for savings and better outcomes. So it's great.
I think the other thing too is that with these patients, some of them, we may not reap the benefits of the investments that we've made in their preventive care if they don't stay with us as a medical group. There is some transiency in terms of members moving in and out, and so we do it because it's the right thing to do.
Don, did you have your? No, sorry. Go ahead, Richard.
No, I appreciate the presentation, and I think kudos for all the things that you're trying to do. I would make note, obviously one example was the diabetes is that sometimes what happens is people actually have unmet needs they didn't even know about, right? And so investing in increasing screening and so forth improves the quality of care, but not necessarily decreases the cost. In fact, you now find things you now have to take care of, and you talk about if you have a transient, if people are switching plans or networks or so forth, your investment may lead to a savings overall, but it's not going to come in your side. It's going to be for the person who they switch to, because that's where the benefit lands. And I think that's one of the things I think we're going to have to be careful about when we talk about dinging who, because it depends on how many new people are coming in. So you're picking up the investment or lack investment of the previous person, and then somebody else is benefiting from yours. I guess the other question I have, and maybe whether you have the answer or not, is that, it sounds like you're doing everything you can. We can argue about, so what is your per member per month cost? Has it been increasing or staying the same or decreasing? And if it's been increasing, by how much each year, despite all of this?
We haven't calculated the specific population health spend in a per member per month way, but in terms of overall cost, it's been increasing, and that's been driven by, you mentioned pharmaceutical cost. That's tremendous, yeah, and staffing costs as well.
Okay, so I think those were some of the things we have to take out. So this is for a system that's doing what everyone's saying, hey, et cetera, and you're driving down some of the utilization, et cetera. And it takes an investment to make these things happen, right? And not just once, as you said, right? You do once and you get it up and it comes down and it levels off, and you got to do another one and another one, right? And we don't want to stifle that. And I think and at the same time, and I know we had this whole conversation about risk adjustment and so forth. What the other challenge is that everyone says, oh, look, if I have a diabetes, Sharp's going to take the best care of me. So I have diabetes, I'm going to go to Sharp. I don't have diabetes, but now they're charging more because they're taking care of all these people with diabetes and they're investing in that. So I'm going to go somewhere else. That becomes a problem, right? And how do we be sure we treat systems fairly, because you may provide the lowest possible cost for people at risk for diabetes, but you may not necessarily benefit from on the cost side, because actually you're attracting a higher proportion of those patients because of your investments and the quality, and people starting to recognize it.
Yeah, I think that's a great point, and Stacy definitely says things like that. And then the other question we have is also, because we manage diabetes so well, maybe we don't get the risk adjustment because they don't progress to being as ill as they would be in a different system. So and do we have adverse selection? I think that's a great question.
And I think to your point, I would also just clarify, to continue these gains, this is work that continues every single day, right? We have people doing touch points, making sure that you're getting your labs checked that year, that you're on track. So there's not something that's you get them there and you walk away and it disappears. It's a chronic illness. So as we continue to build out programs, because we really want to focus on wellness, this is who we are, right? And we use diabetes as an example, but it's breast cancer screening, right? It takes a lot of work. We screen roughly about 85% of our patients with breast cancer. That's pretty good, but it takes a ton of work to do that. And it takes a data analytics team to produce reports that say, okay, Jane here is behind. She hasn't had it done in a while. Let's notify someone. That notification goes out. Physician's office goes, oh, you know what? Jane hasn't been in here. She's pretty healthy, but she needs a breast cancer screening to be done. She needs a mammogram done. Someone has to do that outreach. We need to have the mammogram machines and then the radiologist to read those things and the tech. So all those costs are going up over years, but it's the right thing to do because we have to make these investments to take care of our patients. And this is really what we all consider standard of care.
Thank you.
Okay, other questions? All right, seeing none, just thank you for the presentation. Very much appreciate it.
We'll now move to public comment.
Yes.
Wonderful. So we'll now take public comment. Individuals in the room, please step to the podium. Those online, please raise your hand. To the individual in the room, go ahead.
Beth Capel for Health Access. Like the members of the board, we are encouraged by the efforts of various organizations to try and improve care and reduce costs. We also recognize that that's a process and it doesn't happen overnight. So it's part of the reason why there's a long time horizon on the work that we're doing. Thank you.
Thank you. Looking to the individual online, Travis, we see your hand raised. You're unmuted on our end. Please go ahead.
Hey, thank you so much. This is Travis West, Regulatory Policy Specialist with California Nurses Association. Again, thank you to the OCA board for opening this important question of how providers will meet cost targets in California. On the topic of cost savings measures by healthcare plans, CNA wants to reiterate to the OCA board our overall concern, as I'm sure is true of everybody participating today, about cost saving measures that may have the unintended consequence of inappropriately or unnecessarily reducing the quality of care received by patients. For instance, there was some discussion today about remote patient monitoring and using health technologies by patients in their home. While these measures may lower costs, the board should monitor cost-saving measures to ensure that in-person care is not reduced or replaced by technology, and that care responsibilities are not inappropriately shifted onto the patient, potentially lowering the overall quality of care the patient is receiving. This is particularly true if remote monitoring and other care technologies are used to replace rather than supplement in-person care. Cost savings technology just shouldn't replace human workers' assessment and professional judgment. When considering cost-saving measures, we encourage OCA and the board to create guardrails and monitor for cost-saving practices that may erode the quality of care received by patients. And this is particularly important when it comes to implementing new technologies or modes of care. Thank you so much.
Thank you. Going back to the individual at the podium in the room.
Hi, Carrie Sanders with CPEN. Really appreciate the presentations today, and heartened to hear about examples of how doulas, community health workers, using the additional health workers can really help to improve health outcomes, reduce costs. I'm excited to hear this. And, I think with the SHARP example, I'm really left, thinking, we want to see this type of and this level of care for everybody. So, it's great that they've been able to innovate, and I really appreciate the way that they have shared, what's working. And, so many people are not getting, I just keep thinking about all the people who are not getting basic services, who are not even able to access those basic services. And, when we're paying into a system of care where we're, hoping to see people using and accessing preventative services, let's make that level of service available to everyone. Thank you.
Thank you. Looking back to individuals online, please raise your hand if you'd like to make a comment. Noting for the record, we have roughly 90 virtual attendees at this point. Seeing no hands raised, looking to the room. Seeing no one at the podium, that concludes public comment on this agenda item.
Okay, thank you to our presenters again and the board, and just a good conversation. Hopefully we'll keep, this will be a theme, right? Today too, more to come. All right, THC, Vishal, CJ actually, sorry, CJ, to you.
All right, good afternoon. I will, in the interest of time, attempt to move through this pretty quickly, but wanted to give an update on where we are at with the total healthcare expenditures regulations and the data submission guide, and what our next steps will be, and respond to the comments, many of the comments that we received, and provide the board with an update on modifications that we've made to the reg package that we published in October. So again, as we're very versed in now, I think in these rooms with these timelines, so we published the draft regulations in October. We held a public workshop in November, discussed the regs with the advisory committee in November. The written public comment period closed on December 1. We had a board discussion in December, and now we're going to have the board update today, and I believe we're still on track for submitting the regs to the Office of Administrative Law in February for the regs to ultimately become effective in the spring of 2024, so that we can collect the data necessary for our initial baseline report that would be forthcoming in 2025. So going through the comments, the way this is structured is I'll give a summary of what the comment or question that we received was, and then what OCA's response or modifications may have been based off of those comments. So there was a request for clarity on how to prevent double counting of total healthcare expenditures when fully integrated delivery systems are contracted with another payer. In short, the proposed regs require that the directly contracted plan obtain any necessary data from the subcontracted plan and submit that data to OCA. So again, we'd only be getting the expenditures from one entity. There's a request for clarity on how payers should determine which commercial category to report spend in. OCA will amend the data submission guide to create a new section titled Market Categories, which includes added language and examples clarifying the distinction between the commercial full claims and commercial partial claims market categories. And I'll run through all of these, and obviously we can stop at the end or we can stop.
What is the difference between full claims and partial claims? I don't know what that means. Let's come back. We'll come back. Okay. Keep going, CJ.
Or Michael, you want to come up, or do we want to roll through these and then we can take questions?
Let's just roll and
we'll
keep that one. We have it registered.
So there was a desire for a standardized patient attribution methodology and more clear guidance on how to attribute member spending, especially under the payer-developed attribution method. OCA will amend the language to clarify that attribution is calculated based on mutually exclusive member months and clarify the order of operations regarding the mutually exclusive attribution. There's another comment regarding the absence of a process for validating or disputing expenditures. OCA acknowledges that there may be some variation across payers and fully integrated delivery systems, and OCA acknowledges that not all TME will be attributed to physician organizations. We are attempting to collect the data that is needed to implement our statutorily defined goals, though we do also note that we may not incorporate all of the data that we collect in our baseline data collection. All of the data that we collect may not be implemented or reported on in our baseline or annual reports and may not use all of the data for reporting, enforcement, or accountability. Of course, we are planning to continue to refine our attribution methodologies to inform future data collection and future reporting. We received another comment, several comments regarding the attribution addendum. One was there's an inadequate list of physician organizations in the attribution addendum. We will update the addendum, and we plan to continually and periodically update as we receive more information from submitters. All of these updates would go through the Office of Administrative Law. There was also concern voiced over omitting physician groups with 25 or more physicians. Again, we plan to and will continue to amend the attribution addendum for known groups. There was also a noted need for physician organization registry. We acknowledge and we are going to continually need to refine the list of physician organizations. This will be an ongoing body of work. There was another comment that the office should include the most pertinent portions of the data submission guide directly into the proposed regulations. The regulations are incorporated as a part of the regulations as a matter of law. OCA determined that publishing the guide in the California Code of Regulations would be complicated and that a user-friendly guide is most appropriate means of communicating this technical information to technology specialists that would be responsible for conducting the reporting. This approach is also familiar to the submitters of HCI's HPD program and those that participate in spending target programs in other states. We received comments regarding the lack of a mechanism for gathering clinical risk information that could punish providers who serve particularly vulnerable populations, including a request to formally evaluate alternative risk adjustment methodologies. OCA will not modify its risk adjustment methodology to consider clinical risk through these proposed regulations. OCA staff indicated at the September 2023 board meeting that age and sex adjustments will be, that the data necessary will be collected and likely used in the baseline report. OCA will continue to assess the issue of whether clinical risk adjustment should be introduced into future reporting. We received a comment regarding the authority to collect self-insured data. The regulations require submission of data for all market categories and in accordance with federal law, and update and provide for voluntary submission where the data submission cannot be required. There was a question or comment regarding our authority to collect Medicare Advantage data. OCA is asking for Medicare Advantage data that the state already collects for licensing and plan solvency, just extracted and aggregated and submitted in a format that lends itself to measurement of THCE growth over time. There's a comment that the claims run-out period is insufficient and are inconsistent with state law and will lead to the potential for error. OCA acknowledges that for some claims the run-out may exceed 180-day claims run-out period. This is one of the reasons why the data submission guide requires data submission for the previous 2 calendar years with each annual data submission. Because the 180-day claims run-out period is calculated from December 31st to the most recent reporting year. So in other words, in June 30th of 2024, we would be collecting 2022 and 2023 calendar year data. So there would be a 540-day run-out period for 2022 and a 180-day run-out period for 2023. By collecting that again, when we would go to collect that data in 2025, we'll also be recollecting 2023, and we'll be able to evaluate the impact that the 180-day claims run-out period would have at that time. There was a request for a new definition of allowed amount. OCA did not adopt the suggested definition because the existing language in the proposed regulation is sufficiently clear. There was a request for clarity around administrative cost and profit data collection. The data necessary to collect administrative costs and profits for other submitters will be sourced from existing state and federal reports, including those maintained by the Department of Managed Healthcare, Department of Healthcare Services, CMS Center for Consumer Information and Insurance Oversight, and the National Association of Insurance Commissioners. There was a request for an explanation for why Appendix B does not include non-claims total primary care, non-claims based payment. The instructions for how to calculate the portion of non-claims payments related to primary care will be determined through OCA's primary care subgroup meeting at the investment and payment work group. There was a request for additional clarity around what fully integrated delivery systems will report. The proposed regulations have identical data submission requirements for payers and fully integrated delivery systems. Likewise, OCA's expectations for data accuracy and completeness are identical for payers and FIDs. OCA will continue to engage with fully integrated delivery system stakeholders through this initial data collection process to determine whether the existing service categories and non-claims payment categories meet OCA's data analysis and reporting needs. There was a request to report cost sharing by benefit category, for example, inpatient, to show where costs are being borne by consumers. OCA will not add an additional data field segmenting payer paid and member paid amounts in these initial data collection regulations. OCA is committed to promoting the goal of improved affordability for consumers and purchasers of healthcare and will evaluate the data collected to continue to inform future data collection and reporting. There was a request for new suggested definition of pharmacy rebates. OCA declined to adopt the suggested new definition. The guide will contain a bulleted list of the types of pharmacy rebate data collected in the pharmacy rebates file. Last few, there was a request for changes to the language in Appendix A for service categories. OCA will delete outpatient observation services, critical access hospital, and freestanding emergency facility. There was a request change to the term doctor of medicine or osteopathy. OCA will revise to licensed physician and surgeon. There was a request for stakeholder engagement language added to the guide. So OCA will add a section to the guide, which will read consistent with Health and Safety Code Section 127501.4K. Prior to making any changes to this guide, OCA will engage with relevant stakeholders, hold a public meeting, and solicit input and provide a response to input received. For notice of potential regulatory actions of the public meetings, subscribe to OCA's email listservs. I know that there was already one question. I'm sure that there were others. Can return to the difference between.
Is that our list?
That's it.
Oh,
Yeah.
okay. Rick, I know you have at least.
I could start off and
kind of saw two.
I could start off in answering that partial claim, and then Michael Daly could also add to it once. So there's going to be some services that are carved out. So payers aren't going to get the claims and encounter data. So to the extent that that occurs, carve out services could be pharmacy or behavioral health. We want them to report the available data they have that are claims based. And then if they don't have access to the claims and encounters for carve out services, we want them to estimate that amount so that we could distinguish between what's, what we know from the claims data versus the carve out services that are estimated. Yeah.
Yeah, please keep going.
Thanks. So on slide 102, CJ, thank you for the excellent summary. You've got request to report cost sharing by benefit category, which you said you're not going to do that. What information will you be collecting about cost sharing? Are you collecting it in total, but not by benefit category, or?
So we would know
aggregate.
Yeah, aggregate member responsibility information.
And is the reason not to collect it by service category that sort of undue burden on the reporters? Or?
Yeah, that's one of the considerations. We it is going to be a time-intensive exercise for the payers to put this data together, because we're also asking for attribution to provider organizations and also geographic breakouts. So for the initial data collection, it's going to be more of an aggregate total cost sharing amount. And the request was to, the service categories, inpatient, professional, to kind of break out cost sharing by those categories. Mm-hmm. So at this point, we could consider that in the future.
Have the payers said that would be burdensome to do now?
At multiple points they brought up.
I would think that, particularly probably specialty drugs, there are a lot of employers, I think, moving towards increasing copays for specialty drugs, and being able to kind of keep track of that over time would probably be helpful on the affordability side. But if it's not a this year thing, okay. And then on last question, on slide 95, it says that you will amend the language in the guide to clarify that attribution is calculated on a monthly basis. And I was confused about what that means.
The members would be attributed to an organization on a mutually exclusive months, so that if a member switched organizations from one month to the next,
But you're not going to sort of take 1 month of data and try to attribute them. You're going to take a year's worth of data and look at, or I shouldn't say you, the reporters will presumably take a year's worth of data and look at where the members were getting most of their primary care and do attribution with more than 1 month's worth of data.
Right.
Yeah. Thank you.
It acknowledges that things change throughout the course of the year and uses, my sense is that because things change month to month, you're holding people accountable to build in that change in how they attribute a member to sort of their list, if you will. Is that right?
Yeah, and not only do members change their patterns, but providers change.
Mike.
Sorry, not only do the members change their care seeking patterns, but so do the providers who make up a medical group. It's just to account for the dynamics, Rick, of changing care patterns.
Yeah, but if I have been receiving most of my primary care from one medical group for the last 11 months. And now, for some reason, I get a primary care visit from a different medical group in month 12. That's not going to move me to be attributed.
No, although to be fair, we're not prescribing a standard attribution methodology.
Right.
But generally speaking, no, that would not trigger a change.
Before moving on, Rick, any other? No? Okay. Sandra.
I sort of want to stay on this attribution question. I wonder, I realize that physician organizations change regularly in terms of their membership, and we don't have a common registry. Have you contemplated a partnership with anybody to develop a registry?
This comes up quite a bit. There isn't a source of truth for physician organizations, DMHC. We know the list of RVOs, organizations that come together to form an RVO and have to register. And then we have a list of capitated providers from DMHC. And then there's the whole issue of, multiple, we don't know how they roll up to a parent organization, so we're taking a look at that, our attribution addendum, which is the list of physician organizations for which payers need to attribute medical expense. It's a list that we're going to continue building on. We started off with a smaller list, and it's grown with additional physician organizations, but we're going to need to keep adding to it to making sure we capture as many physician organizations. And we're also asking the payers to help us identify those physician organizations.
If I could just add on to that, the Agency for Healthcare Research and Quality, HRQ, invested quite a bit of resources into a project called the Comparative Health Systems Performance Project. And most of the money went to 3 academic institutions, but part of the money went to a contractor. And part of what that contractor did was work with many different federal data sources to try to create a census of physician organizations. Not perfectly successful, but I think that work could be built upon if there were more resources and interest in doing that.
Yeah, we have met with the team at AHRQ that puts that data set together. I think one limitation is we don't know the contracting arrangements, whether which payers are contracting with those particular systems, but it is going to inform some of our work on the physician organization landscape.
I'll just weigh in because we've had some healthy discussion across different departments within the agency. I think your point, Rick and Sandra, the heart of your question is you could probably make some meaningful progress in this space. Some people have. It is complicated, but potentially, with some degrees of, imprecision, doable. So it's something we've talked a little bit about. And when we think about sort of the amount of data coming into this office, other offices, what we sort of hold with our own contracts even, there might be some opportunities. I think, not that we're just getting started. That's not fair to the team, but certainly it's been a conversation point for others, not just the OCO team. Okay. Other questions on this item? All right, seeing none from the board, we'll go to public comment.
Well, all right, we'll now look to the room for public comment. Please raise your hand online.
Beth Capel, Health Access. So this is a large and complicated endeavor that's going to take us some time. We do appreciate that the staff has now acknowledged that when we were initially presented with regulations, they were read as a fait accompli and the only thing. So the acknowledgement that there will be evolution over time is very helpful. We also appreciate that the comments today are responsive to some of Health Access's concerns, and so we appreciate that. I do also want to note, and actually seems to be on slide 100, that we have a several-year rollout. So as there are technical challenges, which we heard something about yesterday in the advisory committee, and several of the board members have already pointed to, we have some time to try and perfect before we get to the data collection period during that the targets are based on. So I think it's very helpful that the staff has intended to collect a couple of years of data in advance for the baseline report in advance of the target years. So we very much appreciate that. Like others, we would like to see an affiliation registry for providers so that we knew who was associated with what organization, and also a better sense of the contracting arrangements. And we've appreciated some of the work that CHCF has done that's illuminated the variety of relationships in this space. We do hope we will get to cost sharing by benefit category. Maybe this is more obvious to me because of my work at Covered California, where we have a $5,000 or $6,000 deductible for hospital stays, now happily going away, we hope. But, you know, that makes it pretty obvious that people face big cost sharing. And I think you heard earlier that almost 80% of employer coverage now includes deductibles. And so people face significant cost sharing. There are other sources of data on cost sharing, including the rate studies that are done by DMHC, and we would commend consideration of those. Thank you.
Thank you. Looking to those attending virtually, please raise your hand. Seeing no hands raised at this time, noting we have about 88 virtual attendees, we'll move back to individuals in the room. Please step to the podium.
Thank you, Nick Luizos with the California Association of Health Plan. Again, I'll be brief. Our members appreciate being a part of these discussions around the THCE. Again, it's important work that we don't believe should be rushed. While we understand that OCA's goal is to issue the regulations or finalize those and move quickly and provide later guidance to resolve some of the unresolved questions, we believe that would be a mistake since critical issues have not been resolved from our perspective. Issues that have not been resolved, according to my member health plans, measuring healthcare costs at the provider level. There are some workability issues that we outlined in our comment letter, both in December and the one that we issued recently as well. A measurement approach that doesn't work for the marketplace because there's no first order differentiation between PPO and the HMO marketplace. And we think that'll lead to inaccurate measurements of the healthcare spend. Unresolved questions about measuring hospital pricing and other significant cost drivers like pharmaceutical costs. So as such, our CAP recommends that, OCA, refrain from finalizing those regulations until those issues are resolved. And thank you. We look forward to being a part of the continued discussions around this and the spending target. Thanks.
Thank you. Looking virtually, please raise your hand if you'd like to make a comment. Seeing no hands raised at this time, going back to the individual in the room at the podium.
Hi, Ben Johnson, California Hospital Association. Thank you for the update on the proposed regulations on data collection. Just a couple brief comments. First, we are disappointed not to see further movement towards a more transparent and standardized approach around how this data is collected and made available, particularly with regard to the attribution methodology. So would look to see further changes there. Second, have some outstanding questions, I think, still on how Medi-Cal expenditures representing $140 billion of spending in the state are going to be collected and merged with this data to get a true picture of what total healthcare expenditures are going to look like. So seek further information there. And would just request that draft of these regulations be posted as soon as possible and prior to submission to the Office of Administrative Law to allow for proper second round of feedback. Thank you.
Thank you. Continuing public comment, looking online, please raise your hand if you'd like to make a comment. Seeing no hands raised, looking back to the room, please step to the podium. Seeing no one at this time in the room or virtually,
making comment. This concludes public comment on this agenda item.
Okay. Let's keep moving, if that is okay with everybody. Yes, we're caught up and we're going to outperform the agenda. Okay, sort of a reasonable segue from some comments. Vishal, do you want to take us into our last agenda item?
Yes, this is an agenda item for hospital measurement. It's an introductory discussion of OCA's plan for measuring hospital spending. Before I introduce our consulting team, I'd like to give some context for this item. The total healthcare expenditure or total medical expense measurement approach was step one. OCA initially focused on total healthcare expenditure data collection from payers and fully integrated delivery systems because they must submit data by September 1st of 2024. Collecting baseline data from payers and fully integrated delivery systems allows OCA to gain understanding of payer reporting capabilities. This is so that OCA doesn't impose unnecessary reporting burdens on other healthcare entities like hospitals and other providers. Total healthcare expenditure data collection will be an iterative process requiring updates and additions to the attribution addendum that lists physician organizations for which payers are able to attribute total medical expense. And exploring approaches to hospital measurement is step two and aligns with the statute's timeline for measurement of healthcare entity performance against the target. Now I'd like to introduce the team from Friedman Healthcare who are helping with OCA's plan for measuring hospital spending. First, Dr. John Friedman, President and Chief Executive Officer of Friedman Healthcare, is an internist by training and brings 25 years of experience in performance measurement and improvement in healthcare market dynamics. Mary Jo Condon, a principal consultant with the team, supports OCA in its primary care, alternative payment model, and behavioral health work streams. Sarah Lindberg is a senior data science consultant. Prior to joining the team, she spent over 6 years working at the state of Vermont's chief healthcare regulator, the Green Mountain Care Board, overseeing the establishment of 15 hospital budgets, assisting in the development of financial targets for Vermont's all-payer ACO model. Lastly, Gary Swan, a senior consultant, brings a decade of experience in state healthcare administration and leading provider organizations. At the Washington State Healthcare Authority, he implemented innovative CMS population health payment policies. And with that, I'll turn it over to the Friedman Healthcare team.
Thank you, Vishal. So as Vishal mentioned, my name is Mary Jo Condon. I'm a principal consultant with Friedman Healthcare. Today, we are going to introduce you to a discussion of OCA's plan for measuring hospital spending. So next slide, please. So as you have discussed in several of your previous meetings, measuring progress towards spending targets typically focuses on calculating total medical expenditures for a population, essentially how much that population spent on healthcare services. So far, those conversations have focused on looking at a population covered by a payer or spending for a population attributed to a physician organization. OCA's current approach will measure spending performance for hospitals that are part of a health system with attributed lives. However, OCA will need additional strategies to understand hospital spending across all patients and how that spending is contributing to the state's progress towards achieving its statewide spending target. So if we go to the next slide, I want to start with some common language. So for the purposes of our conversation today, when we refer to hospitals, we're really referring to a facility that provides emergency services and outpatient services and inpatient care. And when we talk about physician organizations, we're thinking of a group of physicians and other healthcare professionals who work together to provide a wide range of medical services. And again, for the purposes of today's conversation, in that physician organization bucket, we're going to exclude those who are employed by hospitals. And then last, we have the health systems, a network of healthcare facilities that provide both inpatient and outpatient care, as well as those professional services. Essentially, it's a physician organization and a hospital sitting under the same organizational umbrella. So let's go to our next slide. I want to take a minute to walk through some of what we hope to accomplish over the next several months of work. First, we really want to better understand what methodologies are currently out there and their trade-offs, and specifically how those trade-offs would impact results in California. What would be the disadvantages and advantages specific to California? Next, we want to evaluate the data, both data that's already available and potentially if additional data needs to be gathered, and how we would use that data to support various methodologies and any challenges that might arise. Then we will use the information gained to recommend an approach to measure and track hospital spending and how that spending is contributing to the state's progress towards achieving the statewide spending target. Last, we'll provide some recommendations for accountability. I want to emphasize that OCA will be working with stakeholders, including all of you and the advisory committee, as it goes through this work. There's going to be some other opportunities for stakeholders to engage, and my colleague Gary Swan will talk more about those in just a few moments. If we go to the next slide, we wanted to show a little bit about how various methodologies all contribute to measuring progress towards the statewide spending target. So on the left, we have the methods that have been discussed previously. Basically, measuring total medical expenditures to a population of patients either covered by a payer or attributed to a physician organization. And then on the right, we have the measurement approaches that we'll be working on next. Essentially looking at the role of hospital spending and how that spending is contributing to the state achieving the statewide spending target. This type of evaluation often focuses on changes in price, but it can also look in changes in total payments to hospitals. If you go to the next slide, this is really why it's so important that OCA monitor hospital spending as it works to slow spending growth. The data in this pie chart comes from the Centers for Medicare and Medicaid Services, and if you look at that slice of orange, that shows that nearly 40 cents on every dollar spent on healthcare in California goes to pay for hospital care. If you go to the next slide, you'll see that it's not only a large portion of total spending, but also a significant driver of growth. So there's another bigger trend on this slide that I think really points to why we're all here. If you look at those items in red, you'll see things like hospital services, medical services, education, childcare, food, housing. These are the things we can't live without. Our families can't live without them. Our society can't live without them. And if you look down at the bottom of that list, you see average hourly wage. And so essentially, these things that we can't live without are becoming more and more unaffordable. Let's go to the next slide, please. Before I turn it over to my colleagues to walk through some of the more specifics, I just want to take a second to go through some additional terms, some more common language. Cost and price and total spending can mean really different things to different stakeholders in different situations. So for the purposes of today's conversation, when we say cost, specifically hospital cost, we're really referring to the total fixed and variable expenses to provide a service. And that includes the supplies and the staff and all of the overhead that it takes to furnish that service. When we say hospital price, we're really referring to the price for a unit of service. And then when we say total spending, we're looking at those prices paid for each service, multiplying them by the number of units of service. And because there's differences in the prices paid for different types of service, that's essentially the mix or the intensity of services, looking at that as well. So now I'd like to turn it over to my colleague, Senior Data Science Consultant Sarah Lindberg. Thanks, Mary Jo. If you'd please advance the slide. Here we have a visual representation of some of the concepts that Mary Jo was just discussing with us. And what it's designed to do is just show us 3 different lenses of total medical expenditures for 3 different populations. So the payers are going to have data on the services provided to the lives they cover, whether or not they're attributed. And some of those are attributed to physician organizations, and we will see hospital spending for them. However, not all hospital spending is going to be for attributed patients, so there'll be an overlap, but an incomplete one. And so I think it's critical that we are able to measure that hospital spend in its totality for the reasons we were just discussing. It's not only a large proportion of your total medical expenditure, but it's also increasing rapidly. So to turn our attention to some California-specific data on the next slide, we looked at results from the RAND Corporation's Hospital Price Transparency Study. The most recent round was released in 2022. And for those of you unfamiliar with RAND, they're a nonpartisan organization that tackles public policy challenges. And their scope of work is quite broad, but does include healthcare. This study is pretty innovative. It was an effort to better understand hospital prices and its impact on employers. And they were able to compile quite a bit of claims data from self-insured employers, 11 state all-payer claims databases, as well as several national health plans, which got them to over 4,000 hospitals represented in the data set in 2018 through 2020. And their methodology was to take claims paid by commercial payers and reprice those based on Medicare's grouping and pricing algorithms to give a relative comparison of the differential. In California, there were reliable data for 201 hospitals for inpatient care and 256 hospitals on the outpatient side. Now, it's important to note that these data are largely comprised of self-funded employer claims, capturing fee-for-service payments to hospitals. However, these findings are directionally consistent and speak to the larger trends we're seeing in hospital spending. And I think it also speaks to the critical importance of the work ahead of us to better define these metrics and measurements so that we can more accurately capture hospital spending as a whole. So the next slide will show the results in that most recent round. So each dot is a hospital in the RAND data set. California hospitals are highlighted in blue. And as you can see, the California median as compared to Medicare is 222% of that Medicare cost, so 2 times what Medicare would have paid for comparable services, which is 8% higher than observed nationally at 206%. You can also observe a large variation in hospital prices, both within and outside of California, but the distribution here is largely bell-shaped, tapering off at 0 and approaching 600% of Medicare on the upper end. The next slide will show the same information on the outpatient setting, and it pops out that the variation is even greater on the outpatient side. And once again, the California hospitals in blue have a median outpatient relative price higher than that observed nationally. In California, it's 344% of Medicare price versus the national median of 246, which is 40% higher. The slide, I think, underscores the necessity for improved data and more precise metrics to improve our understanding of hospital spending and its impact on Californians. I'm now going to pass this presentation over to Dr. John Friedman, President and CEO, who will discuss measurement methodologies and their considerations.
Thanks, Sarah. You can go to the next slide. So when you look at, for example, those RAND data that Sarah just showed, it's like, well, how did they do the math and come up with that? And essentially, there's 2 different ways of coming up with an aggregate way of assessing prices. One of them we're very familiar with, sort of the Consumer Price Index, which is known by a term of art, direct standardization. It's a lot of syllables, and I apologize for that, but I didn't coin the term. A different way of doing it has an even one more syllable, and that's called indirect standardization. So I'm going to walk you through what the 2 of these are and try to contrast them for you. Both of them are similar. In that they will compare prices based on a standard set of services. Both of them will measure the negotiated allowed amount prices that are paid by the payer. Both of them, if desired, can be adjusted for any desired set of risk factors such as demographic differences or disease characteristics. And both of them allow for assessing change over time or across different geographies or different groups of or categories of interest. The real difference, though, is that direct standardization does not account for each hospital's specific mix of services. What it does instead is it uses a market basket like the Consumer Price Index. What that means is that over time, if you're tracking the performance of a given institution, if the mix of services changes, it will not be reflected accurately in the measure of price that you come from there, that you get from that. So each has its advantages and drawbacks, and we'll look at them in the next few slides. So let's go on to the next slide, please. And so looking at direct standardization in particular, as highlighted before, it compares a market basket of services. And so it uses those services as if they are deemed to be reflective of what would be typical and what would be average. And again, I'll just use an example from the Consumer Price Index. If the Consumer Price Index basically says the average person buys a dozen eggs and 1 gallon of gas every week, well, then that's what it costs. And that might be very useful. However, if I am allergic to eggs or I'm just trying to lower my cholesterol and I don't eat eggs, then that's not so relevant to me. And if I happen to drive a gas guzzling vehicle and I need 2 gallons of gas and not 1, then it may work as sort of a national crude average, but it doesn't apply to me. And so is there a way to get to more specific details for a specific evaluated hospital? So since direct standardization has that consistent mix of services, it doesn't catch that change in pricing or the effect of that pricing when there's a difference in shift in services and utilization. So some of those trade-offs include that if a hospital service mix diverges from the market basket, then it may become less indicative of what was actually performed. This can be applied. The good news is you can apply this to inpatient or outpatient services or professional services. And it can also be, but it is constrained, by the services included in the market basket. It does not consider variations in the service mix, which can limit and thereby a given hospital may be advantaged or disadvantaged by this and may make it appear that its price is higher or lower than it actually is. And when a specific hospital's mix deviates from the market basket, you may need to make an adjustment for that. So let's go to the next slide, talk about an example here. So this is an actual example done using direct standardization, a market basket of hospital outpatient services over in Massachusetts. And the graph that you're looking at shows a variety of hospital systems. The size of the dot represents the size of the system, so the big dots are the larger ones. And what you see on the x-axis is what the market basket average price is. More expensive is to the right. And the y-axis represents the change or the growth rate. And so faster growing prices are reflected towards the top of the slide. So it's a helpful way of being able to show the trade-off between the price and the change in price using this sort of market basket approach. Go to the next slide. And now I'll talk a little bit about indirect standardization, where you can make the adjustments for the difference in mix. So this also uses a standard set of services, but it does make that adjustment for mix. The trade-offs include the following. It helps to prevent skewed results by accounting for the mix. Considering that you adjust for each hospital's unique service changes, using a broad or universal set of services may make it a little bit more difficult to identify a specific cost driver. This can also, like direct standardization, be applied to hospital inpatient, hospital outpatient, professional services, etc. Okay, go to the next, one more point on this slide. But by considering the unique mix of services in each hospital, it mitigates against unfairly sort of penalizing or rewarding a hospital based on their particular mix at any point in time. So the next slide will give an example of this. And if you can advance the slide, we'll show an example from New York State, which used indirect standardization to look at the actual mix of hospital discharges and services rendered by different categories of hospital in New York. So this is 4 different categories: academic hospitals, and then large, medium, and small community hospitals, and compares what their average prices are. And again, it's able to give this report out a number, a value for each of these, but take into account what the differences in mix are that each of them may have. All right, we can go to the next slide. And we've got another example here of indirect standardization, and this is actually California-specific data. We took the hospital financial data from the financial reports that are submitted and looked at net patient service revenue by inpatient discharge. And again, this is adjusted by the actual mix of services that were rendered in each particular year. And so the result shows the average payment for a discharge starting at $18,000, ending at $27,000, made to California hospitals over that time. Okay, let's go on to the next slide, and we'll do a comparison. Okay, so this is now where you got to sit up and pay attention, because we're going to do a little math and talk about how these differ. So we've got an example here. This is some hypothetical hospital, and we're going to track their actual results over 4 years. Importantly, and to simplify it, we're going to assume there's only 2 services that are rendered here. One is they treat heart attacks, myocardial infarction, that's in green, or they deliver babies, that's in blue. Okay, so we'll keep it simple in that way. And for each of those services, they have their own price, and there's a benchmark price, and that benchmark price might be their historical average, say, okay, or it could be the state average, or it could be the Medicare price, but we're going to compare them to the benchmark price. So in the first year, this hospital does 100 cases of heart attacks, 100 babies delivered. They charge $2,000 for each of those services. And so for each of those services, they collect $200,000. 100 deliveries, $2,000 a piece, $200,000, same for the heart attacks. So if they were to be charging the benchmark price of $1,000, they would have had revenue of $200,000. But in fact, because they're charging twice the price, they had $400,000 in revenue. So using indirect standardization, you divide those two. You say they had $400,000. You expected them to have $200,000. So their ratio is 2.0. They are twice as expensive as expected. And if you look at a market basket approach, that is the direct standardization, DS, what you'll do is you'll say, well, let's assume that they follow the standard average, which is they have an equal number of cases of deliveries and heart attacks, which in fact they happen to do, and look at the prices. Their prices are twice as high. You come up with the exact same result. So in this particular case, both methods, indirect standardization and direct standardization, come up with the identical result. This hospital is twice as expensive as benchmark. And the reason they have the same result is because this hospital actually has the exact same service mix as the benchmark case, equal 50-50 split. In year 2, we're going to come up with both the same result for direct and indirect standardization because the mix will remain the same, but the prices change. So in this case, the hospital cuts its price on heart attacks. They cut their price by half, from $2,000 to $1,000. So their revenue for heart attacks is 100 cases at $1,000 each, is $100,000. That's less than the $200,000 in year 1. For the babies, it's the exact same price, the exact same revenue. So again, against the benchmark, they would have been expected to have $200,000 in revenue, but in fact, they had $300,000 in revenue. So they are 50% more expensive than the benchmark, but if you compare them to year 1, that's actually a 25% decrease in their price from year 1 to year 2. So that's reflected there. You see that under both the IS and DS columns there, they're at 1.5, that is 50% above the benchmark, but year over year trend minus 25%. They're coming down. Okay, now here's where the mix is going to change, and this is where these 2 methods will diverge. So in year 3, this hospital does a lot more obstetrics. Maybe an obstetrics unit nearby closed down and they absorbed the volume. Maybe they recruited some outstanding professionals. Maybe they had to shut down some of their cardiac services. Who knows? These things happen. And so although they have the same total volume of cases, more of their cases are in babies. And the baby deliveries are the more expensive service for them. All right, that's the one they charge $2,000 for compared to $1,000 for the heart attacks. Again, doing the math, you add up their total revenue, and their total revenue that they get for those 200 cases comes to $350,000 compared to the $200,000 you would have expected if they charged the benchmark price. means that they collected 175% of what was expected. You would say they're 75% more expensive than average based on what they actually do. However, if you use a market basket, the market basket ignores the fact that they're delivering more babies than they are treating heart attacks. The market basket assumes that they have a 50-50 mix. They don't really pay any attention to what their actual mix is. And so under a market basket approach, it just simply averages the two prices of 1,000 and 2,000 and says they're 50% more expensive than average. That's obviously a considerable difference. And if you were tracking the trends under indirect standardization, you'd say their prices went up by another 17%. Whereas if you were tracking it under the market basket, direct standardization, you'd say there was no change at all. And obviously, those cannot be reconciled. And then just to round out the example, let's go to year 4. Let's say the volume switches back the other way, and they lose a lot of those. They lose volume in their pricey services, and they gain volume in their inexpensive services. Then what happens is their revenue falls from 350,000 to 250,000, which is only 25% more than the benchmark amount. And so this hospital is really 25% more expensive than benchmark according to their actual mix of services. However, if you look at a market basket which ignores their mix of services and assumes that they have a 50-50 mix, they once again still think that they're 50% more expensive. It will be misleading to use the direct standardization if you've got the data available to make those adjustments based on volume. Let me stop there. There's a lot on that slide, and I'll invite your questions now.
Don, I would like you to ask the first question.
I'm just trying to understand. So one of the things that when we think about as purchasers when we think about hospitals, obviously we care about how expensive the services that are provided in the hospital are. The other thing we think about is the volume issue. So we try to move people out of hospitals when clinically they're taken care of as well or sometimes better out of hospitals. And there are hospitals, when we partner in this endeavor, there are hospitals that probably because of larger financial relationships make that easy for us, and there are hospitals that do not. How do we factor that piece in here? The site of care issue and the whether you're keeping people longer than you need to. I mean, some of that seems to be picked up by the market basket approach, but I worry that some of that may be lost.
So there's two different parts to your question, I think. One is that the actual number of units becomes really important. If you've got a provider that uses far more bed days, units of service than another, that ends up costing more regardless of the price per unit. I think that's part of what you're saying. If you have more difficulty getting someone out of their care system when you have a site of care. Okay.
All right. The harder case is when you may be well, why don't you keep on going?
So, well, I'll try to answer. So this method that I'm describing today will only address the part of it that's related only to price and not to the quantity and volume part. It does adjust just for the mixes in volume in calculating what the average price, the true weighted average price is, but it doesn't deal with the broader utilization. So, for example, if you have, hospital A that has supposedly a much lower price than hospital B, but hospital B is so efficient at moving people out or refusing to admit them and saying, no, this person can just get home care, that you may be better off using hospital B because as part of that global package. So this is one part of the pie, which is price, which is one of the factors that goes into total cost of care. Now, in a fully capitated arrangement where you've got an attributed patient and you can follow them through, then the intent is that we will capture all of those costs related to that person and be able to incorporate that. And you'd see it. But a sizable number of California patients are not attributable in such a manner. And so we need an alternative way of gathering the costs and figuring out where those funds flow.
Sorry, in that environment, we don't have a mechanism for capturing that.
So we will be able to capture the total spend on them, but we'll also, because the number one driver of price changes, of spending changes is price, okay? In a typical year, about 70% of the change in spending is due not to change in volume, not to aging population, not to new technologies, it's due to price. This will serve to provide a lot of intelligence about what's sort of going on among the principal driver, but it will not capture all of those factors. However, it's a really strong way to get started.
Thanks for the presentation. A question may be more appropriate for Vishal and colleagues, but where would the data for any of this come from?
Well, the data is going to come from multiple sources. So we're going to be using some of the existing files that are already available, but a lot of it's going to come from the health payments database. And that's where we will be able to for example, know what are the hospital inpatient expenditures, what are the cases that are being used, et cetera.
Yeah, that makes sense. And do you have any estimate of...
Before, Rick, we're going to evaluate kind of the full range of options for data. With the specific, we're going to be intentional about leveraging existing data if it's available, particularly the HCI annual financial disclosures. So there's going to be a process. Well, in our next steps, we'll talk about a work group that we're going to convene. So we do intend to fully explore kind of what makes sense.
Right, but I mean, the HBD seems like the logical place to get a lot of this from.
Yeah, we'll need to evaluate whether it could meet the needs of OCA for this purpose.
Okay, and then Sarah presented a Venn diagram that I think was just meant to be illustrative. Do you have any estimate of how much of hospital spend will be for attributed versus unattributed patients?
Not at this point. So I don't know if you've got some historical data that gives a sense, but I don't have that.
Or from other states that have done similar kinds of things?
Well, California is going to be different than any other state, so I wouldn't want to extrapolate another state's numbers to that.
Yeah, I mean, Kaiser clearly really different, but we've got much more HMO, much more managed care. It would be helpful, I think, as we're moving forward, to try to understand kind of how important is this to be able to have that kind of, some rough estimate of. I imagine we're talking about a fair amount of hospital spending to unattributed patients, but if it turns out that, it's only going to be 5 or 10%, then maybe we don't want to put too much effort into it, or less effort into it than if it's going to be 40%.
Yeah, our baseline data collection, we'll start some of that in terms of being able to see how much payers can attribute. Mary Jo, were you going to add something?
I would just say that from looking at data from the Integrated Healthcare Association and other existing sources, I think that we know that a really significant portion, particularly of California's commercially insured members, are covered under capitated arrangements. And then in addition to that, you'll have the proportion of members who can be attributed because they're part of an ACO-like arrangement with risk settlement payments. So I think when we add those together, it really is a significant portion of the market that we'll capture through those attributed lives. And then in addition to that, though, we still do have a lot of unattributable members. And so this will help do that. And I think that this also provides a little bit different view, right? So the total cost of care data collection is really helpful in understanding that total spending number, but it's not as helpful in understanding changes in price. And so in order to understand sort of both of those factors, I think this will be an important additional work stream.
That makes sense. And I would just sort of second Don's or comment about the importance of also paying attention to volume, particularly on the outpatient side. Whereas, so much of spending is, and, I imagine that we have big differences, large differences across health systems in outpatient hospital volume, where some systems are doing all kinds of work in the outpatient hospital. And even if they're not charging a lot per unit of service, it ends up being really, really expensive. And other systems will.
It's generally been the outpatient hospital outpatient has generally been the largest growing component of hospital cost total, and that's certainly true around the country. There's been an increasing shift from the inpatient to the outpatient space, which is terrific, generally speaking, but it's an important consideration when you're trying to figure out what the total costs of care are.
Yeah, shifting from inpatient to outpatient is one thing. Shifting from ambulatory care to outpatient is another, which I think has also been happening.
Rich?
Yeah, no, I appreciate the presentation and the complexities. First of all, a couple of observations. The slide in which you show health hospital prices significant driver, but actually, if you look more carefully at the slide, goes back to a point I made about Bauma's cost disease. And so when we think about healthcare versus other, and other services that are essentially expert people intensive versus manufacturing. So everything under the more affordable, like TVs, toys, cell phone service, clothing, health, these are all things we manufacture. At the top, and in fact, you could probably list a bunch of other things, are services where you don't get the same, quote, efficiencies in terms of, an auto worker can produce a lot more cars now than, than they 20 years ago, than now or 40 years ago. But a teacher can't teach the same magnitude of number of people in the classroom, right? You sort of tap out at a certain point. You only have so many kids you can pay attention to, right? And it's how many patients and nurses can take care of, how many patients a doctor can take care of, or other healthcare professionals. So, so I think we need to acknowledge that when it comes to healthcare costs, in the same way we should acknowledge it whether it comes to teaching, comes to other types of that type of service work. That we're not going to get the same kind of quote unquote efficiencies that happen. So I think that graph was actually a great illustration of that trend that is known in economic circles. The other interesting thing I would just make note is that the charts on the hospital reimbursement, where you said, obviously California is above the national, but interesting enough, cost of living in California, most people say is about 42% higher than the rest of the nation. And actually our hospital reimbursement is actually, it's above the national, but it's actually below the cost of living that we have here in California. So just to put that into comparison. But I think one of the things that also is we're talking about inpatient, outpatient, right, or ambulatory and inpatient, as we do more things in the outpatient, which is good, right? And I see this as a program director, resident program director. Our challenge is we have resident physicians and we're trying to teach them is that the intensity of work that's happening in the hospital. So of course I'm looking at the resident physician end has gone up. In the old days when you're a resident, you actually got sleep when you're on call. You still need to be on call and you got woken up, but now it's like you're not really going to sleep very much at all. And so that intensity that happens probably reflects both, and it's good. We're taking people who are not as sick and not bringing them into the hospital. But that also means that the people who are in the hospital are going to cost more because they require much more intensive care, right? Not just the people in the ICU. So I think when we're trying to look at what we call hospital costs, and then where do you call, so okay, what's outpatient that's in the hospital, what's outpatient that's not in the hospital, right? So as we try to do this, I think we're gonna have to be careful to be sure we're capturing apples and apples and oranges, and also that if just because inpatient, costs are going, cost and price are not the same, but I would not be surprised that inpatient costs go up because intensity of the patients that are now admitted to hospital are much higher than they were before. At least in talking to my colleagues, obviously it can be different depending on the hospital in which geographic area they are. And actually rural hospitals, interesting enough, their problem is they have fixed costs they can't spread out among those patients, and then they end up closing. So we're going to have to figure that out. We need to be sure we have an understanding of that and not just go, oh, look, your costs are going up. Well, it's not maybe it's because you just jacked your price, but maybe it's because you actually, there are other secular trends that are happening that not only not having your hospital, but to other hospitals as well.
Thank you. All right, with that, I'm going to hand it over to my colleague, Gary Swan.
Slide, please. Take us to the next slide. Sorry. So I get to close this out. In the coming months, we plan to assemble a technical advisory panel of experts tasked with reviewing the methodologies and measurement tools at our disposal. Their insights will aid in evaluating the strengths and/or weaknesses of each approach. FHC will collaborate with OCA to develop and refine a measurement strategy. In the short term, we will begin data discovery to pinpoint various data requirements, and we'll perform initial analyses using available information. As we begin to define specific metrics, we will model measures for both the technical advisory panel and the board. Once the technical advisory panel convenes and we conduct preliminary assessments, we will provide updates to the board and plan to meet regularly at this forum. Next slide. So highlighting our work over the next several months, we aim to identify members for the technical advisory panel and convene the panel. We will be preparing in-depth materials for their review and guidance. So taking this from the high level to the specific. Our agenda includes testing and modeling various measurement methodologies throughout 2024, identifying methodological gaps and/or data needs, and formulating recommendations to overcome potential measurement challenges. If additional data collection is needed, this effort could result in new regulations beginning in 2025. That's what we have for today. Thank you.
Okay, Elizabeth, go for it.
Thank you. This might be a basic question, but will you be integrating like the TIC data, the new sort of transparency and coverage data that's actually sharing allowed amounts and negotiated rates? Because that, going back to Don's point about how purchasers actually use the information, getting to those standardized numbers across hospitals would be super helpful.
Yes, definitely on the list of data sources for us to evaluate. I think one of the questions is to ensure that there's sufficient completeness across the hospitals of that data. As you're aware, there has been some challenges in ensuring that that data is sufficiently complete.
And then maybe another basic question. I assume the hospitals will actually be identified in the reporting, not just dots?
So I don't think we've gotten there yet, right? Or Vishal? I'll turn that to you.
Yeah, this is just an exploratory or an introductory conversation, but we would need to go through the process, getting feedback about kind of what public reporting would look like. We do have a charge to do some transparent reporting about healthcare entity performance. So we'll need to kind of see what data sources are there that are reliable for us to do public reporting.
And it would be particularly maybe enlightening to understand how one hospital does it at 100% below Medicare and one is 1,200 above. So that could be a nice improvement opportunity to know who they are.
The RAND data set online does name names, so yeah.
Other questions? Looking around? No? All right, thank you.
I did want to get back to Rick's question about, whether the attribution method is this a 5% problem? It's not going to be as small as 5%, which is why we're building out this process so that we can have additional measures to look at hospital spending performance.
I mean, that makes sense, but it does seem possible that it could be 20%. I mean, it's about the IHA data, I think, are about 60% of commercial and Medicare patients are in HMOs, I think, my memory. Yeah, or Elizabeth. Or Elizabeth. I haven't looked at it for a while. I'm like, Or maybe,
Yeah, we have pulled that data and I don't have it in front of me, but if we could follow up with you with
Beth
that
probably
number,
knows,
that
but,
that would be helpful. And I will also emphasize that I think that, that information again will be really helpful to understand that big picture total spending number at that organizational level, but and by service category. But I think that there's additional data sources, many of which have already been assembled, that go into more granularity and can isolate changes in price, which may also be helpful.
Certainly important. But if it is sort of 60%, maybe in HMOs, and then I don't know what fraction of the PPO patients will be attributable, but maybe if it's half, then it may only be 20% of hospital spending that's on unattributed patients.
We'll get that number to Vishal and he can follow up with you.
Okay, one last question, Mary Jo, maybe.
Sure. Based on my notes, that IHA represents approximately 88% of commercial fully insured market in California. Commercial. Sorry, does that answer? Is that the question?
No, I think it's a little different. It's the portion of the commercial market that is either one in a category 4, like HMO.
Can you speak into the microphone? I'm sorry.
Sorry. For category 3 and 4, in terms of shared savings and capitation, population-based payment, that's 99% of the commercial fully insured market.
99.
Are you?
I think it's different. I think we'll follow up.
Okay.
Yeah.
Okay, that sounds.
For HMOs? Oh, for HMOs, but also the PPO.
Yeah. Yeah. For PPOs and, okay. We can definitely follow up, but for commercial APM adoption for category 3 and 4 in PPOs, it's around 16%.
That's right. So we'll follow up with the full population number after we add them all up. Elizabeth, did you have another question?
Just a quick question. Did you consider and decide not to use the Health Partners Total Cost of Care and Resource Use measure set? I know you have some experience with that, and it has some nice insights into price versus utilization, which is helpful for purchasers.
I think we're evaluating all different types of methodologies, and it's a good one to add to the list.
Sure.
Okay, other questions? No? I think it's important for context, just because I've received some reach out on this, and I'll just say it more publicly. This is an introduction conversation. Very much grateful for the presentation. The start of the questions, obviously, the hospital cost center, if you will, is a very important one for us to understand in the broader context of what we're doing on the board. I don't want this to be perceived as the big first step or jumping into the whole sector conversation, because that's going to be an important one for us. They're related, of course, but we have our work to do in both spaces, and I just want to make sure that that's clear for everyone, that this conversation will be an ongoing one. Okay, so we made it to the end. Thank you for the presentation. I'm going to ask that we have back-to-back public comment periods. We're just going to combine them, so feel free, if you're a member of the public want to respond to the presentation we just talked about or any other part of the meeting, please come forward in the room or virtually, and we can open up that time.
All right, it's now open. Public comment is now open. We will start with a hand raised virtually. Steve, you are unmuted. Please go ahead.
Steve McDougall.
Go ahead.
Can you hear me now?
Yes, go ahead.
Steve McDougall with CFT and Mixed Sig based in Salinas, California. One of the things that's been happening in Monterey County that I'm going to use sarcasm, that's really genius, is doctors' practices, many of which have been bought up by the hospitals and the hospital entities, the provider entities, are creating a niche clinical practices called VIP or concierge services, where folks who have $1,000 laying around annually can have the privilege of remaining with their doctor. They'll get a letter from their doctor saying, if you don't want to pay that $1,000, here's a couple of doctors you can jump to. And when they do that research, they find out they can't jump to those doctors. They're already filled up, or they're doing the same thing. So what does that mean? Well, if someone's on Medi-Cal, do you think they have $1,000 kicking around every year in their pocket? No, they don't. So where are they going to end up? In the ER, of course, right where we don't want them most of the time, because they don't need to be in the ER for much of what they need. What a genius little operation, cottage industry they have down in Monterey County. And sorry I couldn't be there in person for the back half of this meeting, but I'm here virtually. Thank you, everybody. Thank you for your time, and thank you for listening.
Thank you. Looking for individuals in the room, please step to the podium, and individuals online, please raise your hand. Right. Seeing no one in the room at the podium, looking back online, we have about 80 virtual attendees at this time. We're taking public comment both on the last agenda item and general public comment. Seeing no hands raised and no one at the podium, that concludes public comment.
All right, I'm going to jump to adjourn our meeting. I want to thank you all, especially those who came at the beginning and stayed till the end. We really appreciate you. Okay, thanks, board members of the board, for all your thoughtful questions and insights.